Hola, Samer. Hola, Víctor.
Hola, hola, Pablo. Hola, hola. Qué gusto.
Hola.
Hello.
Hi, Samer. How are you? How was the case?
Good. I just finished 10 minutes ago and I have fetal surgery in 1 hour.
Hola, Samer. Hola, Víctor.
Hola,
Hi.
hola, hola, Pablo.
Now,
Qué gusto.
Hola.
it was on YouTube.
Hello, Dr. Kanan. How are you, Professor? You're muted. You're muted, I believe.
Imad, you are muted. We cannot hear you.
Pablo, hi.
Now.
Great work. Wonderful. Ready? Oh, you are done? Oh, you are halfway. You left the facial intact in place?
Yes, for the time being, but I'm still on it.
I always wait for the
Still have time to damage it.
vestibular schwannoma. Always you have to wait to the end of it. Yeah. Stefan, good to see you. Samer, wonderful. Professor Samer, first time with us. Nice to have you on the team.
My honor and my pleasure. Thank you, Professor.
And Vladimir Junior, we have to put Junior. You will stay young for life.
Thank you. Hopefully.
Yeah. And Victor.
Hello,
Victor,
dear friend. How are you?
must be very early morning at your place.
No, it's about 8 o'clock. It's not
So these
early.
changes were perfect for you. You start
It's cold.
Yeah.
Yeah.
Wonderful. Great.
Pablo, can I try?
Hi, Vladimir. Hi, Stefan.
Hi, Pablo.
Good to see you.
Pablo, can I try sharing my screen to make sure it's working?
Can you try?
Go ahead.
Perfect.
Good.
Therapy or
Perfect.
oral inhibitor, such as the intravenous cannula, seem to be safe and effective. In elective treatments requiring antiplatelet therapy,
Stefan, is it possible that you have something playing around?
Not in my computer.
I think it's Stefan. Is it possible?
Stellar therapy might be guided with a genotypic test or with a platelet function test. But nowadays, the
Stefan, can you hear us?
where they demonstrated clinical test.
Stefan.
Yes.
Can you hear us? Is it possible that you have something playing around?
So I was in the webinar until now, but I closed it, but I don't know how it's. Yes.
Ramesh, welcome on board.
Hello.
Hi, Ramesh. How are you?
Good to see you all. It's a long time.
See you a long time, yeah. Yeah, I'm all fresh with the new year.
Yes.
Thank you for this wonderful presentation. This is something we have all been having a lot of doubts on.
Which video is running today now? The audio of which is for Professor Samer?
I think it's
No.
Stefan has something.
Stefan.
Now we cannot hear you, Stefan. You are muted now.
I was in the webinar with, and I cannot close it. I will close everything and I come back.
Okay.
You have time for this. Pablo, we are expecting few guests. We send them the correspondence. Some of them, they are interested to be on. If we have the chance during discussion, then we might privilege some of them to give input.
Sure.
I think Dr. I think Rosna from USA. There are a few of them. They are interested to be with us, and we welcome them as it goes.
And I can see Takashi Kon around, so I'm inviting him. Let's see, Stefan.
No. It's better now?
It's perfect.
Perfect.
Clear, like water.
I close it. I don't know how. It remains in the background. I don't know
Now it's
how.
perfect.
Okay.
Thank you. Ramesh, can I make you host just in case?
Ramesh, unmute yourself, Ramesh.
I know. This is sometimes the lower part of the screen gets blocked by the taskbar, so I'm trying to figure out.
I put the dashboard in the left side.
Oh, okay. Yeah, I should do that. Thanks for the tip.
So can I make you host?
Yeah,
Ramesh,
please do.
Because my internet connection is quite unstable.
That's okay.
Good morning.
And I see Professor Chandra Shekhar there,
Yeah.
but not the picture.
Picture of Vancouver.
Professor Chandra, are you with us? It looks like his image is there, yeah. So while we are waiting, Pablo, we just give a chat with them that will tell them that we have several projects on top of the webinars, and we are excited. We've made some changes, Pablo and myself, giving more time for the presentation, 15 to 20 minutes each. And we restricted the number of presentation to 6. We used to present over 4.5 hours, 5 hours, you remember, in the old days. And this will give more concise and focused presentation, and we leave a half an hour with the discussant to discuss the paper, or any questions comes to mind, any information can be of value for education and teaching will be in that discussions as well. And raised a question by QR from the audience, we might check 1 or 2 from them if the time allowed during the end of the presentations. Pablo, you want to add a few things if you want to give on the new changes we have?
Nothing else, despite the fact that we are planning to have this webinar every 2-3 months. We didn't decide yet, and to have it shorter on specific topics. And that I'm very happy that this one is going to be on pediatric, which is a topic that we were missing somehow in the past. And the most exciting thing is that I'm watching on the screen some of my best friends everywhere. So I cannot be more happy. Thank you.
Thank you. We will be complement our webinar with some on-site activities. We encourage all of you to have potential collaboration with the local society, regional society, other conferences. And of course, we cannot be all there, but at least some of them. But I prefer the on-site contribution to be physically present. So otherwise it make a duplication of webinars, and we don't want to repeat what we have done in the past. So we have enough staff to be at different sites. At the same time, we will conduct our webinars as usual. So the first one will be, I think, Professor Vladimir Benish, Senior. He is coordinating a collaboration with the group.
Dr. Elbaba is starting. Sorry, Matt. Sorry.
Yeah, with the group from the minimal invasive access in Phoenix, Arizona, with Professor Elias from Malaysia and Professor Yoko Koto. He invited the members to contribute, and we prefer to have a physical contribution. At the same time, Professor Miguel Reyes has kindly invited us to joint venture with him with the Spanish Society in May on the 7th at the pre-conference course IANA with the Spanish Society and the Neuroanatomy Committee. These are the upcoming 2 activities. There is one, I think, where Professor Roy Daniel has established a group for. When is this, Pablo? Roy Daniel?
The end of May in Lausanne, 27 and 28 May.
So May is a full activities, and we might interrupt the webinars during Christmas and New Year. This is one time, and during the summer holiday. So at least we have 6 to 8 webinars per year as it goes.
Stefan is going to say something, I guess. Stefan, can you unmute? You're muted.
I would like to launch the invitation from now. We have our National Society Congress, in which I am now the president. Last year we organized in Târgu Mureș the IANA webinar more. It was online. Only one of the members were present. Now in September from 8 to 11, please join us, our society. It will be a great honor for us to have as much as you can present on site in Sinaia. Sinaia, it's a very nice location. It's in the mountains, so you are all welcome.
Thank you. September, we have time to plan now. Very good.
Pablo, we should proceed now. I think it's time.
I think we are ready. Yeah, we had 375 people that we have. Now we have 80. So I think we should start.
Okay. So welcome, Moody. I'm seeing Moody just joined us as well. And Roy is with us on the lower screen. Wonderful to have all of you. Without further ado, I'd like to invite all the people watching us on this webinar and all the members who are contributed or been active to the end to start our first webinar for this year, and it will be on pediatric subject. And the first session will be chaired by Professor Ramesh and myself, and I will give the venue for Professor Ramesh to present the first speaker. Professor Ramesh.
Thank you, Imad, and it's a great start for the new year, and hope just like we're starting with the pediatric session, I hope this is going to grow the whole this year. We're going to grow as a society and have more engagement in future, and grow into adulthood and remain there as an adult, not becoming an older person. Anyway, so I'm very glad to ask Professor Samir Al-Baba to speak on the assisted endoscope controlled approach to pineal region, which is a very interesting topic. And whether you are a pediatric neurosurgeon or an adult neurosurgeon, this is an area of interest to all of us. So it will be good to see this. And thank you for coming to our session. Thanks very much. Samir, all yours.
Thank you, Professor Nair. And I'm greatly honored to join this esteemed group of colleagues in the International Academy of Neurosurgical Anatomy. We are all in the right cause, doing the right work for our patients while we understand anatomy very well. I cannot thank enough my dear friend, brother Pablo Gonzalez, for all the years of friendship and getting me to fall in love with neurosurgical anatomy. Thanks to you and to Professor Kanan for including me in this esteemed group of colleagues. The goal of this talk is to focus on different approaches. We all get tied to endoscopy or microsurgery. Whenever I deal with patients and with pathologies in the pineal region, I really try to complement everything I have with me in the operating room. It doesn't matter if we use microscope, endoscope assisted or endoscope controlled approaches. What matters is we get the work done safely. We all know that the pineal region is very unique in its anatomy and its depth. And the goal is to get the work done safely without interfering with the surrounding brain anatomy as well as the venous anatomy. So whenever I deal with a baby, like in this MRI, a 7-month-old baby with a giant mass in the pineal region, severe hydrocephalus, how can I complement all technologies and techniques and expertise in microsurgery and endoscopy to get the work done safely? In general, the three main approaches for microsurgery have been posterior transcallosal, posterior interhemispheric, transtentorial, or supracerebellar infratentorial to the pineal region. But we have to remember, whenever we look at the pineal region, over 50% of the pathologies are germ cell tumors. Whenever we deal with germ cell tumors, we always need to obtain tissue diagnosis first, because many of them, like germinomas, can be managed successfully with adjuvant therapy, with chemotherapy plus minus radiation. This is a slide I borrowed from my dear friend Pablo. I love this slide. It talks about whenever we deal with pathologies that are in depth, deeply seated lesions, or in the ventricular system, or even the pineal region, we have to think always about the ideal cortical gray matter entry points or white matter tracts that are being traversed whenever we decide about this such approaches. We always talk about motor and speech areas, visual tracts, thalamocortical tracts, and corticospinal tracts whenever we deal with deeply seated lesions. That's why I love this slide from Pablo. But my mentor and our mentor, Professor Yasago, taught me early in my career that actually the whole brain is eloquent. And whenever we decide to do any approach, it doesn't matter if we do microsurgery or endoscopy, we need to get the work done safely through anatomical corridors and avoid any morbidity or potential mortality. So whenever we discuss those three main approaches, and if we use microsurgery or endoscopy, we can mainly divide them into supratentorial or infratentorial approach. But even in the infratentorial approach, we have the median or paramedian supracerebellar approaches to the pineal region or upper brainstem. Anatomical landmarks are essential. Here are excellent anatomical models from the lab in Alicante from Pablo and his colleagues, showing that whenever we deal with supracerebellar approaches, we have obviously to understand the anatomical landmarks, the inion, the external landmarks for the transverse and sigmoid junction. Some colleagues prefer to perform a craniotomy that covers both supra and infratentorial. In my practice, I stopped doing any supratentorial extension of the craniotomy, and I focus on the infratentorial window. The reason is that the more and more my practice is more heading into endoscope-controlled supracerebellar approaches rather than purely microsurgical. Once the dura is open, understanding the venous anatomy is essential. Finding the landmarks for the torculae, the transverse sinuses, as well as, especially if we do median approaches, the first thing we're going to deal with are inferior vermian veins or hemispheric veins. Typically, the superficial ones are safe to sacrifice, but as we dig deeper, or as if we go lateral, we have to preserve all the veins as much as possible to avoid any venous infarcts or even posterior fossa syndrome. And again, understanding the venous anatomy and the entry coming in the supracerebellar, if we sacrifice the inferior vermian veins over the midline, those are okay. But as we go lateral and venous attachments into the petrosal sinuses, or as we dig deeper into the precentral vein, basal veins of Rosenthal, this is the anatomy we have to preserve. Whenever we decide about approaches, either endoscopy or microsurgery, we have to always think about the tentorial angle. To start with, how can we differentiate endoscopy from endoscope-controlled to endoscope-assisted techniques? Endoscopic, especially for the residents and the students, endoscopic is when we use the working channel to get the work done. This is like when we do ETV or ventricular endoscopic work. Endoscope-controlled is when we're using the endoscope for visualization, and the surgeon is using the instruments in parallel to the endoscope, similar to transsphenoidal approaches, or even endoscope-controlled supracerebellar approaches. Endoscope-assisted is when the endoscope is used during certain parts of the operation. And as late Professor Pernetsky described the field of endoscope-assisted microsurgery as a minimally invasive technique with maximally effective outcomes. So whenever we use endoscopes, we can use as a 0, 30, 45, or even 70-degree endoscopes. And it is truly not right to have attacks between endoscopy and microsurgery, They both actually have their goal during the surgery. And I don't mind during the surgery to go back and forth between microsurgery and endoscopy for getting the job done. Whenever we look at the best approaches, semi-sitting position historically has been truly the workhorse or the best approach whenever we do supracerebellar approaches. Semi-sitting position, we have to think about the tentorial angle, the cardiac anatomy, risk of complications. Professor Yassergul, when they summarized the Zurich group, talked about over 1,000 patients done in the sitting position. The truth is, we're all shifting away from sitting to semi-sitting position, and even in the pediatric population, with challenges related to putting pins in the skull of young children, still semi-sitting position is feasible, can be done safely. In our practice at our children's hospital, whenever I decide to do a semi-sitting position, the angle should not be more than 45 degrees. We do preoperative echocardiogram to look for PFO. We do intraoperative subclavian central line, subclavian or transjugular, and we do intraoperative transesophageal echo, and we do 3-minute intervals to avoid heating of the esophagus. If we do evaluate preoperatively and find there's a patent foramen ovale with shunting, we switch to prone position. But even if there is a PFO, you may consider a cardiologist doing elective closure. Again, looking at the pathology in pineal region tumors, over 50% are germ cell tumors, so it's very common for us whenever we deal with kids with pineal region tumors with hydrocephalus. We go ahead and start with endoscopic biopsy of the tumor and endoscopic thermoventriculostomy at the same time. Doing the endoscopic biopsy of the pineal region via the same approach for the ETV versus a more anterior approach, this is, in my opinion, should not be decided before surgery. It should be decided intraoperatively. Every time I go, I'm planning to do both, like different approaches, but I decide intraoperatively based on the anatomy of the choroidal fissure as well as the foramen of Monro, if I'm able to do it safely or not. In this case, we used a hairline entry point. You can see here we're accessing the third ventricle endoscopically, working on the space over the massa intermedia to perform the biopsy. In this case, it came back as pineoblastoma, and this was resected via supracerebellar infratentorial approach. This is a similar patient, but a 15-year-old with headaches, blurred vision, nausea, same thing, pineal region tumor. In this case, always we plan for 2 different approaches. After the biopsy was done, this came back as a germinoma, was treated successfully with adjuvant therapy. So here 2 patients, both pineal region tumors with hydrocephalus, one treated with resection, the other one with adjuvant therapy. This is a 16-year-old we treated a few months ago, severe headaches, upward gaze palsy, normal CSF markers. We can see this enhancing mass. Again, when I go in, I'm always planning to do 1 incision with 2 entry points. One classic for the ETV around the coronal suture. The other one is a base at the anterior hairline. And when I go intraoperatively, I decide to do 1 or 2 approaches. Like in this case, I'm doing now the ETV. ETV is uneventful, being done, and I'm pleased with the fenestration. Now, I'm looking now at the anatomy of the choroidal fissure as well as the foramen of Monro, and this anatomy is allowing me to achieve a successful biopsy without significant or any mass effect or putting any pressure on the veins in the choroidal fissure or the fornix. And in this case, a successful endoscopic biopsy was done, came back as germinoma, and adjuvant therapy melted the tumor away. How about this girl with chronic headaches? I've been watching her for pineal cyst. Typically, we do not operate on pineal cyst. In this case, it increased in size, and the proteinaceous material inside the cyst became concerning. Again, whenever we decide about approaches, we have to remember this child or this young teenager does not have hydrocephalus. Again, we go back to the basic approaches: posterior transcallosal, posterior interhemispheric transtentorial, or supracerebellar infratentorial. Semi-sitting position, TEE, you can see it in the mouth of the patient, midline incision. And in this case, decided to do completely endoscope-controlled approach. Now using completely endoscope-controlled approach, after coagulating the inferior vermian veins over the midline, which are safe, now the window is open, and now we're able to achieve the access to the quadrigeminal space safely. The first thing is to do a combination of blunt and sharp microdissection without retractors to identify the anatomy. This anatomy is very essential. I'm looking here at the right thalamus here, vein of Galen, right basal vein of Rosenthal, left basal vein of Rosenthal, left thalamus is here, and the mass is there. Now to go step by step, again, this is all endoscope controlled, right thalamus, vein of Galen. I'm now dissecting the mass from the right basal vein of Rosenthal carefully. And I keep doing this, and I go on the other side, the left basal vein, but I'm always thinking about the internal cerebral veins and possible communication between the internal cerebral veins and the roof of the third ventricle and the mass. After the mass has been dissected free from bilateral basal veins, now dissecting, do a bimanual dissection of the mass, in this case from the right thalamus. After the bimanual dissection has been completed, now again, the last part is to make sure no attachment to the internal cerebral veins or the thalami, and with bimanual dissection, use an endoscope-controlled excision of the mass. Now we take a look, putting the endoscope back, again, vein of Galen, right basal vein, left basal vein, right thalamus, and now we are in the posterior third ventricle. We can see here choroid plexus in the roof of the third ventricle. And the mass has been resected through a very tiny craniotomy, no retraction in the cerebellum, and the mass has been resected and venous anatomy has been reserved. How about microsurgical approaches? This is a 12-year-old girl, severe headaches, vomiting, mildly elevated alpha-fetoprotein. Again, I always go in with the same ETV, endoscopic biopsy, came back as pineoblastoma. But when we did a transesophageal echo, we found she had a wide PFO and shunting, and a decision was made to proceed with a supracellular infratentorial microsurgical technique, but with endoscope-assisted capability if needed. Again, we're looking in with this view. We can see the inferior vermian vein superficially. I was able to sacrifice one, but able to work circumferentially around it. And now we are doing a careful dissection, trying to find the precentral cerebellar vein and dissecting it from the tumor. I try in every case to preserve the precentral cerebellar vein, and in this case, doing ultrasonic aspirator, removing the tumor while working around the vein to preserve it. After we completed the resection of the microscope, I always bring in the endoscope to take a look and make sure we did not leave any residual and the venous anatomy has been preserved. Right basal vein, precentral cerebellum vein, left basal vein of Rosenthal, and now the mass has been resected, and we're looking at the posterior third ventricle. And gross total excision of the mass via endoscope-assisted microsurgical technique. And most importantly, I always like to look postoperatively at the venous anatomy, make sure we preserved it. When we look at our series in Orlando, 28 pediatric cases, all of them are children using semi-sitting position. We had one intraoperative air embolism, which was managed successfully using the classic management, drop the head, flood the field, stop any leak from any venous sinuses or bone air cells. And typically this will do the work. Occasionally, you may ask the anesthesiologist to suck air out of the central line if available. 3 temporary paranoids, all of them resolved, and 1 epidural hematoma after placing a preoperative frontal EVD for severe hydrocephalus. And this can happen in semi-sitting position. And intraoperatively, we have to keep an eye on it. It has been a pleasure to work with colleagues like Pablo, Sebastian, Roy, and Professor Bennett and others, collecting group, excellent collection of cases with a group in Lausanne helped us all collect cases for the extreme lateral supracerebellar approach. And this is truly a great workhorse approach for pathologies in the posterior brainstem, mesial, temporal, hippocampal region, pineal region, and I highly recommend for students and residents to look into this reference paper published in World Neurosurgery, great collection of cases of pathologies in the tentorium, brainstem, pineal region, and mesial temporal area. We use the modified semi-sitting position for also cases whenever we deal with posterior thalamic areas. This approach, I learned it from Professor Ture in Istanbul, performing posterior interhemispheric subsplenial approach for pulvinar or posterior thalamic tumors. We used it in a couple of cases, again, in semilateral position, and this came back as an anaplastic astrocytoma resected via the posterior interhemispheric subsplenial approach. In conclusion, using a combination of microsurgery, endoscope-assisted or endoscope-controlled techniques to manage pathologies in a pineal region can really complement each other as techniques. We should always think in the pineal region, we should always think about pathology and performing early biopsy, and then deciding about a resection versus adjuvant therapy. If we decide about resection, decide about which techniques between microsurgery and endoscopy. Semi-sitting position is safe and, in my opinion, essential in pediatric patients for complex pineal tumors or mesial temporal pathologies. And at the end of the day, the anatomical knowledge and patient selection, careful planning is what matters to achieve the best outcome possible. But we truly need essential partnership with our colleagues and anesthesia team whenever we decide about those approaches. Thank you.
Thank you, Professor El-Baba. That was a wonderful talk. Clearly, you have distinguished the endoscope, purely endoscope control, and using it as a complement to your microsurgical operation. I think that is the key message from this talk. I'll open it out to the discussion. Not sure whether Tom and Professor Pujari, I can see it on the panel. Imad, you want to say something?
I just want to compliment this presentation. Was a wonderful, Professor Samer. You covered it very nicely, with up to date. I want to concur and support what you have said. The exposure of tubercular, even the major signs completely, nowadays I don't do it anymore. You can easily compensate this one by draining some CSF. It gives you the space between the tent and the cerebellum. And you don't need to retract the sinus per se. You need to do any retraction, if at all, more in the depth. This is one important. The unilateral approach you mentioned, now we try to shift to it, and it's a wonderful approach. And you don't go into the hassle unless it's going to the contralateral side of the lesions. One more thing I say, I notice the bimanual technique when you do pure endoscopic technique is fantastic, but I like the first step to identify the arachnoid, peel the arachnoid a little bit, and then you do the endoscopic manual technique. So you avoid putting on the arachnoid because, as you know, most of the vessels and the veins, they are in the subarachnoid space and they will be affected, either vessels by spasm or bleeding or venous by thrombosis. These are the two notes, but a wonderful presentation. Thank you.
Thank you, Professor.
We're having the discussion at the end of the session, Yeah, so should we
will have half an hour later on for discussions.
Fine, okay. Should we go on to Professor Vladimir Benish Jr.?
Good afternoon, ladies and gentlemen. It's very great honor for me to be invited into this distinct group, and I would like to share my thoughts on cerebral mutism and tumors of the fourth ventricle. So let me get that going. No. Screen. Let's see now. Can you see the screen?
Yeah, I think we can see it now.
You can see that. Okay, I'm never sure because I have two monitors and it always messes things up. Okay, now my topic today is tumors of the fourth ventricle and cerebral mutism. And I would like to look at all the factors that can contribute to it, because in the literature, the approach is one of the things that is usually blamed. And I would like to shed more light on it and see if it's the only thing that is to blame. Okay, this is the way. Okay, tumors of the fourth ventricle are rather frequent in the pediatric population, and the localization is in a region where important structures are very abundant, counting cranial nerve nuclei, cerebropeduncles, vermis, neurovascular structures in the PC angle, etc., etc. The role of surgery is to address expansive behavior of the tumor. We restore the CSF circulation, obtain definite histology, and hopefully achieve gross-to-glow resection. This can be curative in many lesions. However, adherence to important neurovascular structures or invasive growth may prevent it. Complications of surgery in this region include motor and gait disturbances, swallowing difficulties, cranial nerve deficits, and most of all, the feared complication is cerebral mutism. This is a complex syndrome which develops most commonly in children as a consequence of posterior fossa surgery. Its symptoms include altered speech production or complete loss of speech, emotional ability, ataxia, hypotonia, and other cerebral symptoms. Most of these symptoms are luckily transient, and patients will improve over time. However, some form of impairment may persist into the future and into adulthood. So let's have a look at which structures are critical, what are the risk factors. That will be more of a literature review. I will share some of my thoughts on the approach to use, how could we modify the surgical technique, and other ways so we could predict mutism onset after the surgery. Let's start with the critical structures. So let's look at the pathophysiology of cerebral mutism. The dentato-rubro-thalamocortical tract is thought to be the culprit of cerebral mutism, and it runs through superior cerebral peduncle. The other anatomical structures involved are the Guillain-Mollaret triangle, which includes the inferior olivary nucleus, red nucleus, and the dentate nucleus. Another pathophysiological phenomenon associated with mutism is probably cerebral diasthesis, which is caused by a loss of excitatory impulses from the cerebellum into the motor and premotor area that leads to hypoperfusion and decreased oxygen consumption of the cerebral cortex, as can be witnessed on SPECT imaging done 24 days, 3 months, and 2 years after posterior fossa surgery. Other possible mechanisms include postoperative edema, perfusion due to vasospasm of surrounding vessels, or vermis disconnection to the cerebral nuclei. What are the risk factors? These could be divided into uncontrollable, that is tumor-related, such as location, size, invasive behavior, and histology, and patient-related, such as age, gender, left-handedness, or pre-op speech impairment. And those risk factors that we can control, that is approach, tissue handling, that's the nicest of the surgery that we do, or our gentleness towards the tissues, whether to use a retractor, use of CUSA, intraoperative MR, and extent of resection. Those are the things that we can, in some sort of ways, control. Let's have a look at the tumor location. A large study done by the Nordic countries included at this moment more than 700 children, and these are some of the preliminary results that shows the fourth ventricle and brainstem to be worse off than cerebral vermis or hemispheric tumors. Obviously, this tumor, which is located in the ventricle, in the hemispheres, then this tumor, which is located in the fourth ventricle, this one will be less likely to develop mutism. Tumor size, 5 centimeters, is sort of a cutoff for mutism development or for predisposition for mutism in all histologies, and especially in medulloblastomas, as we can see by these two meta-analyses. So obviously, this patient would be more prone to have mutism than this patient where we had really trouble finding the tumor for a while. Invasion of the brainstem, fourth ventricle floor, and superior cerebral peduncle are also very very highly influensive factors for cerebral mutism. This is my case for tomorrow or the day after. So I am already afraid of having this patient having mutism, because the pedunculus and the brainstem is very distorted, and I guess the invasion will be in this region. Medulloblastoma histology has been consistently blamed across the literature and across the last decades as a predisposing factor for mutism. So comparing medulloblastoma and ependymoma, this patient actually did have mutism, this one did not. That's just a demonstration. And this was confirmed by the Nordic study, where medulloblastoma and ATRT were more common to have mutism than pilocytic astrocytoma or low-grade gliomas. Age, mutism risk decreases with age. It is a rather rare condition in adults, and that is true both for midline and for hemispherically located tumors. Gender, that's just for completion. There was no influence of gender so far found, and left-handedness is dubious at best, because the ongoing Nordic study did not confirm these data so far. What approach to use? Just a short overview. The transvermian approach splits the vermis. However, splitting the vermis at the beginning of the surgery may reduce traction needed in the later stages of the procedure, and may be advantageous in giant tumors that attenuate the vermis onto a very thin layer of tissue, such as we can see over here. This patient was done by a combination of the two approaches. On the other hand, Telever approach uses natural corridors, splits the cerebromedullary fissure, splits the telechoroidea and velumedullare, and allows for very early control of the fourth ventricle floor, vascular supply of the tumor from the pica. It is easily to extend into the CP angle via foramen of Luschka. Usually, its unilateral application is sufficient. However, lesions in the rostral part of the fourth ventricle or in the fastigium are sometimes difficult to reach via this approach alone. So just a short anatomical overview for the younger colleagues from Rotten collection. The cerebromedullary fissure is over here, that is then dissected, and we see the tela and the velumedullare, which is then transected. I shall demonstrate just a short video of the approach on this low-grade glioma in the fourth ventricle. Hopefully it works. Yeah, okay, so this is suboccipital craniotomy performed. Here we dissect the cerebromedullary fissure, and here we identify the tela and the velum, which will in a short moment be easily transected. And you see the opening of the fourth ventricle, which is gained by this approach. Okay, so that's just for demonstration. And here you see on the DVI images that almost no harm has been done to the surrounding structures. Even large tumors can be rather nicely resected, or the Telever approach gives nice overview of the whole force of the fourth ventricle, and large tumors can be sometimes easily, sometimes not so easily resected. Literature review shows the telovelar approach to be of benefit in regards to cerebral mutism. However, the ongoing CMT study did not confirm that yet, both in univariate and in multivariate analysis, as did our own study performed on 100 patients. There was no difference between the telovelar and the transvermin approaches. My personal preference is to use the Telever approach, because it uses anatomical corridors, does not distort any normal tissue. However, in selected cases, I'm not afraid to do limited vermotomy, about 1 or 2 centimeters, and it's always the tumor that dictates the approach or their combinations. How should we modify the surgical techniques? So just some tips for the younger colleagues. I always respect the arachnoid around the cranial nerves and the anatomical planes that are dictated by the tumor. at the end of the surgery or during more time-extensive surgery, I use papaverine for arteries. Intraoperative monitoring is obviously a must in surgery in these regions. Regarding retractor use, I use it very sparingly, but I do not avoid it at all costs. Sometimes it is necessary, but very, very, very rarely. And if I do use a retractor, I release and reposition it frequently to allow perfusion of the retracted tissue. So we see a small retractor injury in this case over here. CUSA is used for extensive debulking, which is necessary in these tumors. And when I work at the tumor borders, I always put the setting on very low and very precise in order to avoid heat injury of the underlying normal tissue, mainly the cerebral peduncles. I cannot really comment on intraoperative MR since we do not have this possibility, but literature shows that it's advantageous because it avoids over a resection or too much of a resection, and it helps guide the extent of resection. Okay, so let's have a short look at the extent of resection. We always perform frozen section very early, so we know what kind of tumor we are dealing with. And we have a luxury of a very great pediatric neuro-oncological team at the hospital, so we can, in moments of doubt, discuss with them how extensive the resection should be and what their possibilities are. So sometimes we are not aiming for gross total resection, especially in low-grade gliomas. I do not feel the need to resect completely the tumor if it's invasive towards the fourth ventricle floor or if it's very adherent to the cranial nerves in the CP angle. However, in ependymoma, the resection should be always aimed for gross total resection. MRI would be helpful, but as I said, not possible in my department yet. However, we are not afraid of a second look surgery because that's better than morbidity, as you can see in one of my early cases when we left this piece of medulloblastoma behind and returned 2 days later and achieved complete resection without any complications additionally. So no evidence for extent of resection with regard to cerebral mutism in the literature review, similar in our own study published last year in ACTA. Can we predict which patients are more likely to develop cerebral mutism? There is a very nice tool from the Rotterdam group, which takes into account radiological diagnosis, if it's medulloblastoma or other tumor location, brainstem invasion, and cerebral peduncle invasion. And this measurement of the distortion of the brainstem that gives us a score of low, intermediate, and very high risk. So we can counsel the patients or their families better with regard to development of cerebral mutism. In conclusion, mutism is a very frustrating condition for the patient, for the family, and for us as surgeons, because sometimes you do everything right, there is no problem at the surgery, and the patient still develops mutism, and you have no idea what you did wrong. So I always try to do my best to avoid it. I always consent the family with regard to it. I prefer the televiral approach, and obviously there are always things we can do with our surgical technique, always ways to improve it. And I am not afraid to return rather than do harm. It's no shame to return 2 days later if you left something behind. So regarding cerebral mutism, there are still many unresolved issues, and approach is just one of them. And I'd like to invite other participants into the Nordic European CMS study, which has been ongoing for 10 years now. We've been participating for over a year. And it's an easy study to do with almost no administrative difficulties, and would give us hopefully answers in the next few years. Thank you for your attention and for the invitation.
Thank you, Professor Vladimir Benish. It's a great talk. Vexing dilemma for pediatric neurosurgeons especially. I probably would have to, I think we will have the discussion at the end of the session, I believe. And it will go on to the next speaker.
Roy, Ramesh, may I just want to say a few words about Roy?
Please do.
Yeah. Of course, white matter anatomy is a prerequisite for intra-axial tumors surgery and functional neurosurgery in focus, with special on epilepsy. And Roy and the IANA team members, the working group, has made a major contribution to teaching and education of white matter dissection. And Roy has promised to deliver several courses around the year. So I invite all the young neurosurgeons. This is an essential part that the seniors, they have not gone through these exercises, and this is something you have to consider and attend one of Professor Roy Daniel courses on white matter dissection. Go ahead, Ramesh, sorry to interrupt you.
No, I think it's just you've done the introduction, and it's a great pleasure and honor to call my very close friend, Roy. We've seen his papers in the previous lectures as well. Roy, all yours.
Yeah, thank you, Ramesh. Can you see my screen?
Not yet. Waiting to... Are you sharing?
Yes.
You might be sharing your...
Yeah, I got it. I got it. Now?
Yes.
Yes.
Great. So, thank you, Imad, for that good introduction. Thank you very much. And it's a pleasure to talk to you. And thank you, Pablo and Imad, for organizing this pediatric course. We don't do many pediatric courses in neuroanatomy, not enough. And I'm sure Samir will agree with me that it's nice to have a pediatric symposium. So without going too much into that, I just want to focus on what we are discussing today, and it is white matter anatomy and what are the implications for surgery in general. But we have a unique opportunity to study white matter anatomy when we disconnect it. So this is probably the only surgery in our domain where we destroy structures. So when you can destroy structures, you learn a lot about it. So we should take that opportunity to study more of the white matter anatomy. So why do we decide to disconnect the brain, if at all? We never do it, and we are taught not to do it. But the only situation in which you actually disconnect the brain is when you treat epilepsy or other functional disorders. Why do we want to treat it? Because we want to stop the epilepsy. And when we stop epilepsy, we're talking about catastrophic epilepsy, hundreds of thousands of seizures per day that we see in some of our children. They are not able to develop the brain function because the seizures are completely disturbing brain development. So if you see this patient who has one hemisphere completely destroyed by a disease involving which you call an hemispheric epilepsy, there are many types of it, but this is one of them, and that this does not allow the normal brain on the other side to develop function. So if we do not treat it when plasticity is high, you end up with the children who become adults who are developmentally challenged. So that is why we need to disconnect this brain, because this brain is completely sick, and it is only producing epilepsy and not contributing to any meaningful neurological function. And therefore, when you do disconnect this brain, you do not increase their neurological deficits. And even if you do, it is marginal, and that may be the price you pay for the rest of the other hemisphere to become a double hemisphere. And that will allow the rehabilitation of these children and allow them to integrate into society. So we want to allow the good brain to develop by disconnecting the bad brain. So that's the function of disconnective epilepsy surgery. Over the years, we've published a lot of techniques in pediatric epilepsy surgery, and this forms the basis of how I structured the talk so that I can show the white matter anatomy that we disconnect during these procedures, and we'll come to these techniques which we described over the years to illustrate this point. So what is peri-insular hemispherotomy? This is the disease in which one hemisphere is completely destroyed. And this particular patient that you see here, patient had a congenital condition called the Sturge-Weber syndrome, which destroys, which is a leptomeningeal angiomatosis. It destroys the whole hemisphere progressively, and has the child is left with no function, but has intractable epilepsy. And what do we do? In this condition, even though you need to know what the white matter tracks have to be disconnected, it's less of a problem because you're going to disconnect everything in that hemisphere. So better to know the names of every fiber you cut, but you will see as we go along that in effect, disconnection of a whole hemisphere is much easier than a partial disconnection of one hemisphere. So what do we do in this procedure? We go from laterally towards the ventricle. And when you go from laterally towards the ventricle, what you're disconnecting is the entire internal capsule, or at the junction of the corona radiata and internal capsule. So that deafferents the entire hemisphere from the impulses that go down into the spinal cord. Then from inside the ventricle, you cut the corpus callosum that you see here, and you have to cut the entire corpus callosum. So what that achieves is that the impulses, the epileptogenic discharges that start in the sick hemisphere cannot go to the contralateral hemisphere and then get propagated, manifesting as epilepsy. While you're inside the ventricle, you can also cut the fornix, as you show here. And fornix represents the major output of the mesiotemporal lobe, the hippocampus and the amygdala, which is crucial in the pathogenesis of a majority of epilepsy. So that disruption of the fornix achieves a near total disconnection of the output from the hippocampus and the amygdala. And then there's one additional structure that needs to be disconnected. That's the fronto-basal disconnection. So this is a view from the bottom. And why do you want to do that? Because we have to cut also the impulses from the anterior commissure. And you don't want to approach the anterior commissure from a lateral view, and the best way to do it is to do a fronto-basal disconnection, which interrupts the communication of the limbs of the anterior commissure. So that kind of finishes with what is called a radical hemispheric tractotomy. So every white matter fiber that has that connects to the cortex on one side is disrupted. What do you do when the whole hemisphere is not involved? And so you have these conditions, as you see here, in which the temporal, occipital, and the parietal lobes are involved by a disease. Many of them congenital, some of them acquired, but mostly congenital diseases. In this patient, it was a Sturge-Weber again. So there, we have to make sure that the frontal lobe, which is normal, is not affected by our surgery. So we have to disconnect between the frontal lobe and the parietal lobe, just behind the sensory motor strip. And then, of course, you have to deafferent the entire posterior quadrant. So that's why this is called a posterior quadrantotomy. That means the entire output of the temporal, occipital, and parietal lobes are disrupted, and also the associative fibers that go between the frontal lobe and the posterior quadrant has to be disrupted. Otherwise, the epilepsy can go to the normal frontal lobe. At the same time, all the output of the frontal lobe needs to be preserved. So that's the challenge of this particular surgery. And then we go on to another one. This is the inverse situation in which you have the anterior. That means if you go to this, the frontal lobe is diseased and the posterior quadrant is abnormal. So it's the inverse of the situation where the anterior quadrant needs to be disconnected. Now, we had the opportunity to do a lot of very good dissections in Professor Pablo Gonzalez's lab in Alicante, and I'll show you some of the pictures that illustrate the white matter anatomy of the region. Now, imagine a disease of the frontal lobe, which is anterior to the precentral sulcus, and the motor strip is preserved, and you need to disconnect this lobe, that is the frontal lobe anterior to the motor cortex. So an incision needs to be done anterior to it and going on to the basal frontal lobe. So we are looking at the anatomy of this particular region. Now, if you look at this hemisphere from the medial side, that's again the frontal lobe, which is abnormal in this patient. And here you have the genu of the corpus callosum, the rostrum, the subcallosal region, and there you can see a glimpse of the gyrus rectus. Then you have the anterior commissure here and the rest of the corpus callosum. So the incision has to go through the anterior part of the corpus callosum, come across and go on to the basifrontal lobe. That will achieve a disconnection of this lobe. Now, it's also important to appreciate it from the basal surface, because the basal surface anatomy it needs to be appreciated. As you know, you have the gyrus rectus here, which is medial to the olfactory tract. And then lateral to that, you have the classical H-shaped sulci, which divides the basifrontal lobe into 4 gyri, which are the medial, lateral, anterior, and posterior fronto-orbital gyri. So we need to go behind the posterior part, that is through the posterior fronto-orbital gyri to complete the disconnection. So that's how you would disconnect this particular lobe. And then it gives you the opportunity, these disconnections allow you to study the white matter anatomy of this region. So these are dissections done in Alicante. You can see that here. You remove the gray matter, you scrape away the gray matter, you start seeing the U fibers, the fibers that connect one gyri to the adjacent gyri. And then as you keep removing that, you'll start seeing the first associative fiber here, which is the superior longitudinal fasciculus. And we'll see more of that later. It'll divide it into 3, 1, 2, and 3 SLF from top to bottom. Then when you take that out, you start seeing the external capsule. You scrape that off slowly, you start seeing the, you see the extreme capsule here, and then later on you see the external capsule. You start removing it, you start seeing the interesting fibers, the IFOF and the uncinate fasciculus and the IFOF inferiorly here. There you see the external capsule. You can see the remnants which we kept here to give you orientation for the SLF and the U fibers. You start scraping away the external capsule, you start seeing components of the internal capsule. So here you can see the frontopontine fibers, part of the internal capsule. There you see the putamen already here. You go deeper, you start seeing the medial components of the internal capsule. This is the thalamocortical projections. We've kept some of the frontoparietal fibers here. Then you go even deeper, you reach the ventricle. And there you can see the chordae nucleus here and the ependyma of the ventricle. So to be able to disconnect it, you have to cut through all these fibers and reach the ventricle. That completely disconnects from the lateral side the entire output of the frontal lobe. But that's not enough. You need to, and that's a high projection, a high zoom of the incision from the lateral perspective. That's the incision like that. You can see the frontostriatal fibers of the internal capsule, the SLF and the U fibers. And then you need to look at it from medially to understand the anatomy from the other side of the ventricle. So from the medial perspective, you can start seeing the corona radiator there, fibers of the internal capsule. And there here you've cut open the ventricle. So that shows you the fibers that you need to cut to be able to reach there. And what you're cutting, the corpus callosum, is you're cutting the anterior part of the corpus callosum. This specimen, you've done the entire corpus callosum. You don't need to do it for an anterior quadrantotomy. This is just to show you the perspective from medially when you cut and you reach the ventricle, that you cut the genu and the body of the corpus callosum for this particular operation. So if you turn it a little oblique, you can appreciate from the medial perspective the incision that needs to be done. And there you see the genu, the rostrum, the body of the corpus callosum. There you can see a beautiful exposition of the cingulate gyrus. There you can see the fanning out fibers of the corpus callosum, which has been cut here. So the corpus callosal cut is a little in the parasagittal plane. So this picture shows you exactly where we would cut it, in the parasagittal plane and not in the midline plane, which is more familiar to the neurosurgeons. So as you do the frontobasal disconnection, this is the important structure that you want to disrupt, which is the anterior and posterior limbs of the anterior commissure. Now the anterior commissure, from a lateral perspective, it is dangerous to approach the anterior commissure. Why? Because in the midline, just on the other side of the anterior commissure, you have these small perforating arteries that go to both hemispheres, and that can cause major problems with ischemia of the central structures, including the hypothalamus and the subcallosal area. So that's why we cut the anterior commissure a little more laterally, and we would never approach it from a lateral perspective to be able to do a commissurotomy. That we could do from the midline, and I'll show you as we go along. So this is a beautiful dissection done, which shows you, which is a very unusual perspective. It's from the basal surface of the frontal lobe, this disconnection, that shows you what the anatomy from a basal perspective. Now, these kind of images you never see usually, because who would go from a basal perspective to enter the ventricle? So here, if you can see, that's the chiasma here. You can see the anterior commissure beautifully dissected out here, going fanning out. And then you have the corpus callosum that is seen from inside, and the genu of the corpus callosum and the rostrum here. So these are where the disconnections would be to disrupt the anterior commissure. Somewhere here laterally, you would disconnect the anterior commissure. So that's the schematic perspective. So this is from a basal view that you are seeing it. So this is an unusual view, so I thought I'll share this with you. You can move it a little anteriorly and do, for specific conditions, what's called the prefrontal lobotomy. Now, this prefrontal lobotomy done both sides had a bad reputation, even though it got a Nobel Prize many years back for Igas. But this, we're talking about unilateral prefrontal lobotomy for epilepsy. Bifrontal was done many years back before Largactil was discovered to treat schizophrenia. So we're not talking about that disease. We're talking about a unilateral epileptic disease, and in which you do a prefrontal lobotomy. Again, there may be a bit of a repetition, but I just wanted to show you the perspective. This is the skull, shows you the superior temporal line, the pterion. And what you need to do is a small craniotomy that gives you access to this region. Now, in this region, the inferior frontal gyrus has an interesting anatomy. So it has two sulci like that divide it into three. So you have the pars opercularis, the triangularis, and the pars orbitalis. The prefrontal lobotomy is between the last two, that is between triangularis and the opercularis. So many of the anatomy after that is very similar, so I will not repeat it. And this is from a basal perspective that shows you where you need to disconnect it basally. We have discussed this before, and the medial perspective, we have discussed it. The lateral perspective is taken a little anterior for prefrontal lobotomy as opposed to an anterior quadrantotomy where the incision is placed here. The rest of the surgery is exactly the same. So again, these are dissections. I show you U fibers here. IFOF and uncinate fasciculus are dealt with in this particular operation, and the rest of it is exactly as discussed before. So let's run through this. These are all similar images from a medial perspective again, and that from a lateral perspective. So this, from a medial perspective, the incision goes quite anteriorly here. It's not through the body of corpus callosum. It's in the anterior, dealing with the genu and the rostrum essentially. So till now what we discussed is the disconnection of the entire one hemisphere, which is called hemispherotomy. Then we talked about partial lesions. We did the posterior quadrant, we did the anterior quadrant, and then we did the prefrontal lobotomy. Now, what do you do for children who have epilepsy that comes from both hemispheres? Obviously, you cannot do a radical surgery here because you cannot disconnect both hemispheres. So that's an impossibility, and you need to look at palliative options of at least stopping the debilitating epileptic phenomena. So what we are describing in this video, along with beautiful dissections done in Professor Subiano's lab in Tumen, where we have now a large series of children that we have operated for this pathology, and in which we do it endoscopic. So if you were to do a dissection endoscopic and you enter into the third ventricle, so you're in the middle of the third ventricle and you're looking forwards. When you look forwards, you get this very unusual view, which many neurosurgeons would never have seen because the indications don't exist. So if you look anteriorly, you would see the two columns of the fornix, and they form a triangle with the anterior commissure. Okay, and there you have the foramen Monro and the choroid plexus bilaterally. That shows that's the opening into the lateral ventricle on both sides. So here you are in the third ventricle and you're looking forwards. And if you look a little inferior, you will see the lamina terminalis, the imprint of the optic chiasma and the infundibulum. Now, these may not, you won't see it in a patient as such, but these are cadaveric discussion. Now, if you turn your endoscope 180 degrees and you look backwards, you see this beautiful anatomy of the posterior commissure, the aqueduct here, the habenular commissure, and the pineal and the suprapineal recesses. These were areas that Samir well described, but the perspective for those surgeries are from outside. Now, this is a perspective from inside looking outside. So this is what an endoscope will show you if you were to enter into the third ventricle. Now, here we are looking at a basal perspective just to give you an anatomy of the anterior commissure. So the anterior commissure is a large band in the middle here, very close to the optic chiasma, and it divides into two limbs. And it's the anterior limb and the posterior limb, and these are the areas that the posterior limb supplies. So this is the anatomy of the anterior commissure, and there you can see the corpus callosum there. So these are just inferior to the corpus callosum, the genu and the rostrum of the corpus callosum. And this is the anatomy that we want to disconnect, but from the midline. Never ever do this from laterally. It would be too dangerous, I think. Now, to give you a perspective from an image that all neurosurgeons are familiar, because the midline, everybody knows. From the cut in the midline across the hemisphere, we have been learning it from the first day in neurosurgery. You have the genu, the rostrum, the body, and the splenium of the corpus callosum. Then you have the anterior commissure here, and then you have the optic chiasma here, and then of course the infundibulum. You can see that there. And here you have the posterior commissure here. You have the tectum, the aqueduct here, the thalamus in the midline, and the interthalamic adhesion. So this is something, and the brainstem here. This is something that all neurosurgeons are familiar with. But if you turn the specimen a little bit, you can appreciate it even better, because you can see the lamina terminalis in front, the anterior commissure. Now this side has been removed to illustrate the point. This is an external perspective. You can see the optic nerve here, the chiasma, the lamina terminalis here. You have the third nerve from outside. And then inside the third ventricle, you can see the posterior commissure, the aqueduct of Sylvius, the pineal gland, and because that's your tentorial hiatus, and through the tentorial hiatus, you can see the top of the vermis. So this is an interesting perspective. Now, this is the video that can show you what an anterior commissurotomy looks like. So we put in the endoscope, and you would do the part of the surgery with the flexible to start with, because the one with the rigid is a little more bloody, so you don't want to soil the field when you start. So we have gone through the foramen Monro into the third ventricle, and you can see the foramen Monro on the other side, and there between, like if you remember the diagram I showed you, between the two foramen Monro and the columns of Fornix, you will see the anterior commissure, and you just disrupt the anterior commissure with the flexible endoscope. And then you use the value of the flexible endoscope and you turn it 180. Now, this is a maneuver which is not easy to do, and I found it easy to do it along with the urologists who do flexible endoscopy every day, 5 or 6 of them. And these guys are very good, and they help you do it. So they are able to turn the endoscope much easier than us, and they are very happy to do these neurosurgical operations also, or to at least help us do the neurosurgical operations. So you turn it around, and then you look at the posterior third ventricle, and you see the aqueduct of Sylvius there, and then you see just anterior to that, the posterior commissure. Sometimes you see a habenular commissure on top. If you do see that, depending on how much it is evolved or developed, if you see it, you can disrupt that also. So that's what you do. You disrupt the posterior commissure. Now, once you've done all that, then you can remove your flexible endoscope, and the rest of the operation can be done. That's your posterior commissure, which is removed, and you come out of the foramen Monro, and then you come into the ipsilateral lateral ventricle. And then inside the ipsilateral lateral ventricle, you have to disrupt the callosum in the parasagittal plane, just like you would do for a lateral hemispherotomy. So you go through with a monopolar or a bipolar cautery, and you cut across till you reach the tissue next to the fox, either in the pericallosal cistern or just near the cingulum. So either one of them, you just reach the midline near the forks, inferior to the forks, and there you can start seeing the anatomy of the pericallosal cistern. So that's the key. We have to identify one of the vessels there, which are the pericallosal arteries, and you have to follow the pericallosal arteries anteriorly and posterior till the entire callosum is disrupted. So once you identified that, then it becomes very easy. You know exactly what you have to do, and you'll have a large C-shaped callosotomy, which anteriorly will be the rostrum and posteriorly will be the splenium. So and that terminates the operation. And this is always done after the flexible part of the surgery is done. So we'll go on to the last disconnection that I want to present to you, and this is a recent one. Only the last 3 years, we described a surgery for disrupting the central quadrant. Now, what is the central quadrant? That's the quadrant which is between the anterior and part of the posterior. So the part in the middle. Now, that's very difficult because you have to be very selective here. You have to keep the normal frontal lobe intact. You have to keep the normal temporal lobe intact. And you want to keep as many fibers that communicate the anterior to the frontal to the temporal lobe. And you have to disrupt everything that communicates epileptiform discharges from the central quadrant. So I'll run through these pictures. So this central quadrant, what are the landmarks? You have the superior parietal lobule, the supramarginal gyrus, the angular gyrus, and then as you go deeper, you'll start seeing the vertical component of the SLF. And the important one you have to see here is the arcuate fasciculus. Now we have to take all efforts to keep the arcuate fasciculus, especially on the dominant hemisphere, because that's important to communicate the Broca to the Wernicke. Both Broca and Wernicke in these patients are normal. So if you want them to keep talking and understanding, you have to keep the arcuate fasciculus. So that's the challenge of this particular operation. To show you some of the images of the arcuate fasciculus, that's where you would find it. Here you can see that it's intimately associated with the SLF3, the arcuate fibers. And there you can see an axial section that shows you the trajectory of the arcuate fasciculus. Now, while we were doing this dissections of the central quadrant, we listed out all the fibers that we encountered, and we kind of classified them into longitudinal fibers and curved fibers. So you could refer to this article that lists out the whole thing, but that's the appreciation, the fact that some are curved and longitudinal are as important as understanding what are the regions that they connect. Now, to understand it better, we felt it was easier to understand the development, because why is the brain curved in this region is the question. So why did we develop a telencephalic flexure? So if you look at the development, the ontogeny of the process, and as you know, ontogeny, I don't know if you subscribe to this view, it kind of replicates phylogeny. So this is why we looked at animals, embryology of animals, as well as embryology of humans. So you see these flexures developing, the pontine flexure, the cephalic flexure, and then as we reach beyond 8 weeks, you start seeing that the brain starts bending. And why did it bend? Because it had to bend because we needed more space for cortical function to develop as the embryo grows. And that's why it needs to develop in this flexure. So, and if you look at animals, it's exactly the situation. In rats or mice, there is hardly any flexure, but as we go to cats, you see some flexure happening. In primates, like monkeys, you have a reasonable flexure, and in humans, it's the most developed. So it's the same kind of thing that happens in the human embryo. Now, if you look at a cut section of this, you will see what we are talking about. So when we started, the embryo was like this, and then you started getting the flexure, and then it gets deep. And what happens when you get a flexure? That's when you form the sylvian fissure. So these are pictures of human embryos at different weeks. And you see beyond 18 weeks, you have a reasonable flexure that's developed and which kind of remains static after about 33 weeks of development. Now, in this region, because the flexure developed, you develop many of these fibers that become distorted. Now, when the brain developed in that manner, for some reason, I'm sure there is a reason, but let's not discuss it now. It divided these fibers into two. You develop what's called the dorsal stream and the ventral stream. So this is the ventral stream of fibers that are bent, and then you have the dorsal stream that develops. So one part of it pushed anteriorly, another part slightly posteriorly. Both were curved, and that's where that accommodates the basal ganglia and the sylvian fissure that develops. So when you study these fibers, you see that the older CNS tracts are all longitudinal. The ones that are very primitive are longitudinal, and in primates you start seeing curved tracts. And the longitudinal ones are the ones that connect the frontal or adjacent cortices. But the curved ones are more posterior and basal across the flexure, especially those that connect distant cortices like the arcuate fasciculus. So basically, I just wanted to impress on you that there are two streams that developed in humans. One is the ventral stream, which is composed of the IFOF, the uncinate fasciculus, and the anterior commissure, which is curved, all of them, and they're ventral. And behind you have the dorsal stream, which is represented by the MLF, the vertical SLF, and the arcuate fasciculus.
2 minutes.
Yes, I'm done, Imad. And these are all well detailed in this paper that talked about the development of the telencephalic flexure. So we discussed the following procedures: the quadrantotomies, and then the central quadrantotomy, and the total commissurotomy, which is a palliative procedure. That's all I have, and I really acknowledge many institutions that have taken part in it, part of the IANA, and it's a great opportunity to work with neuroscientists from all over the world. Thank you very much.
Thank you, Daniel. I think we'll move to the next session. We keep the discussion later, and I will give over moderation to Professor Pablo Gonzalez. I don't see Igor. Is he in? Then you will be Igor as well.
Yeah, Igor just texted me that he has some duties in the university. He will connect later on. So thank you, Roy, for this wonderful white matter overview based on how we have to cut these tracks. And we move to the next session, in which we will be dealing with some anatomical concepts, vascular, and some functional neurosurgery and oncology. And it's my real pleasure to introduce Professor Stefan Florian from Cluj, Romania. He's the head of the department there, and he's really, really active on teaching everywhere in the world. Indeed, the first time I met him, he was my teacher. So it's a real honor to have him on board today. He's going to talk us about vascular intracranial AVMs at the pediatric age. Thank you, Stefan.
I thank you. So I was really impressed about the anatomy that was presented by Roy. My presentation, it's a little bit more toward a practical pathology, which is the intracranial AVM at the pediatric age. For the beginning, I have to mention that most of these pathologies, vascular pathologies, are developing pathologies which are developed along with the brain of the human being, of the children. So we are speaking about not about an expansive process, a tumor, but more which cause compression, all the other neurological involvement related to the expansion. But we are talking about an abnormal physiology which is integrated in the brain. It's developing along with the brain of the patient. So that's why the surgery, it's somehow difficult, and the consequences of surgery on all the other treatments are not always in the line with what we are doing from a surgical point of view. So I will not insist on definition, but at the pediatric age, pediatric population, in many cases we have diffuse and multifocal lesions. There are remote AVM shunts sometimes. In some cases, we have venous ectasias, high flow. Most of them are high flow lesions. And sometimes we have a single arteriovenous fistula. There are two other more vascular malformation, which are quite frequently encountered in the pathology, in our daily practice, and the cavernomas, which are usually solitary, more frequently described and discovered in adults, but in children, we have more the type of familiar cavernomas, multiple cavernomas, and I remember at least 2 or 3 cases in which I operate the parents of the child, and then the child with brainstem cavernoma. And another pathology which is quite frequently addressed to us is development of venous anomalies. Many people, and especially parents, are coming to me with the described venous anomalies by the radiologist, and we should discuss with them, explain that these are not pathological structures. Usually they do not rupture, and when we have a rupture and hematoma around such a caput medusae venous anomaly, usually we should search for a cavernoma. So at the pediatric age, we know that they tend to rupture more frequently than in adults, and at the pediatric age, these are the most common cause of the spontaneous, so-called spontaneous intraparenchymal hemorrhage. The established annual hemorrhage rate is between 10 and 10% higher in smaller children, and the re-rupture rate, it's about 2 to 4% per year, but this is cumulative. So we should take in consideration when we decide about an AVM, how to treat, and even to treat these risks of rupture and re-rupture, and this is a risk, cumulative risk. And regarding the children, they have long life expectancy, so the recommendation is usually to treat these children. The factors that are influencing hemorrhage are generalized venous ectasia, fast, the high flow AVMs, deep-seated AVMs, and though located in the infratemporal compartment, and those with deep venous drainage. So how to diagnose? Now we know that this diagnosis is essentially imagistic. In emergency, we are performing CT, but in most of the cases, we should perform as soon as possible, and regardless the age. I don't know how it's in your department, but I had a very tough fight with the pediatric neurologist in order to convince them to perform an MRI whenever children is presenting with neurological symptoms, and especially with seizures, in order to discover the what is behind this. Usually they are treating the seizures with medication, and after a couple of years of treatment, they are performing an MRI. In some cases, the cause of a seizure could be an AVM, developing AVM. In others, it could be a tumor. So, in my vision, the cranial MRI, it's mandatory for surgery if it's possible to perform it. In emergency, not always possible, but an angio-CT, it's mandatory regardless the age. So other examination are useful for completing diagnosis, the electroencephalography, in some cases, especially in spinal region, endocrine examination, ophthalmological examination, and for children over 4 years, it's advisable to have a neurophysiological evaluation. So, speaking about pediatrics, especially in Romania, the pediatric neurosurgery, it's not very well covered. We don't have a subspecialization in Romania for pediatric neurosurgery, and not too many people are interested in this. And my feeling is that we need a special training for this, because for many points, the pediatric neurosurgeon should be aware about not only pathology, but also the anatomy, the tiny vessels, the anatomy of the brain. It's not only miniature, but not always well developed, especially in neonates. We have some particularities, and we should train our neurosurgeons, especially those who are interested in neurosurgery, in pediatric neurosurgery, with many aspects. So I put some slides. Why do we need the special training for pediatric neurosurgery? There are also some neuroanesthesiologic consideration. The children have small airways, small respiratory volumes, different weight surface report, so they have hydration particularities, drug administration and metabolism are different from the adults, and the children, especially those very small, have a predisposition to hypothermia and hypovolemia and anemia. These are especially important in surgery of vascular malformation and aneurysm. Speaking about the special training, the children has a thin and delicate scalp, so usually we perform and we prefer the midline incision, and we should avoid the angular incision. The children below 2 years of age have a thin skull, so we should avoid the pin fixation in children younger than 2 years. And we are preferring non-rigid fixation for this kind of patient. And we should have a great attention to prevent blood loss and especially duration of surgery. And for all this, we need a special and experienced surgical team that comprise not only the surgeons and the assistant, but also the anesthesiologist. The children with AVMs usually presenting with hemorrhage. They are discovered abruptly, and most of the patients, almost 60%, of the acute intracranial hemorrhage in the childhood are due to vascular lesions. Half of them, a third of them, are because of the ruptured AVM. 50% due to cavernomas, and only 30% due to a ruptured aneurysm. Another modality of presentation are the seizures, which are mostly encountered for supratemporal cavernomas, and for AVMs, it's the second type of presentation. And progressive neurological deficit without acute hemorrhage, it's not so frequent in AVM, but it's more frequent in cavernomas. Headache are the complaint in some children. For a reason for these patients are investigated, and sometimes it's discovered a vascular malformation or an AVM. In my series of, I didn't update my my personal series since 2021, but in my series of 238 AVMs, operated AVMs, I operate also 34 pediatric cases that represent 14%. Most of them were boys, almost 60% of them. And regarding the peak incident, normally most of the cases are after 10 years of age up to 18. So most of our cases are presented with hemorrhage. In pediatric cases, 45% of the cases are followed by seizures in 30% of the cases. As I already mentioned, MRI, it's the preferred tool of investigation for children, but in emergency, we are performing CT, angio-CT, in order to define the source of hemorrhage and the angio-architecture of malformation. Regarding the digital subtraction angiography, there are, at least in our center, we have no experience with digital subtraction angiography since we didn't have the equipment, necessary equipment, only in the last 3 years introduced. So there are concerns related to the high dose radiation in childhood. So for most of the cases, we are rather prefer, and we are operating on angio-CT and in ruptured AVMs. And for the rest of the cases, we are preferring the MRI, angio-MRI. So based on special Martin classification, most of our cases were grade 2 and 3, and in some cases, 80% of the cases, we have also cases with associated aneurysm proximal on the feeders of the AVM. How to decide? There are many aspects related to this decision making, especially in children. Morgan, in a critical review of brain AVM surgery, stated that the treatment is necessary if the future risk of hemorrhage is higher than the risk of microsurgery, stereotactic radiosurgery, endovascular embolization, or multimodal treatment. We know that the annual, and we underlined previously that the annual rate of first hemorrhage is 2.2%, but it's higher in the children, and there is a cumulative risk of future hemorrhage. Annual re-rupture, it's around 4.5%, a little bit higher in children. And also there is a cumulative risk of future hemorrhage to up to 45% at 20 years. And the risk of permanent neurological deficit or death from hemorrhage is 42%. So comparing this with the risk of surgery, we are aware about the study, Aruba study in Scottish audit, which produced a real earthquake in neurosurgery. Their conclusion that intervention led to a worse outcome compared to the natural history was immediately argued by many neurosurgeons, and among them, I really enjoyed the arguments of Melling, and he stated that these studies compare no treatment with the treatment that are extremely heterogeneous. Compares the stereotactic radiosurgery and embolization, which were the main modality of the treatment in 80% of the treated cases, and only 5% of cases were treated microsurgically as a monotherapy. So from a surgical point of view, this study have no any meaning. And a study of Vladimir Benesh and Bradak estimate that the probability of bleeding in 30 years perspective with conservative treatment is much higher than the treatment of surgery, which is in you can see it's only around 5%. The risk of surgery, the advantage of surgery are that we immediately eliminate the hemorrhage, we decrease the rebleeding risk from the AVM, and we improve the seizure control. The main indication are grade 1 and 2 AVMs, and for majority of the experienced surgeon, grade 3 superficial AVM could be also treated surgically. For grade 4 and 5, the palliative surgery, meaning the removal of the clot and the decompression, are the solution in ruptured AVM. So as a conclusion, surgery is the most versatile and curative option for many patients with AVM. But as I mentioned, surgery is not without risk. And the same author, Morgan, described the risk of surgery, and he underlined the fact that the risk is related to three main factors: the deep venous drainage, eloquent, and size of the lesion. And from 1 to 6 centimeters in patient with no deep venous drainage and no eloquent location, the risk of surgery is between 1 and 9%. For patients with deep venous drainage and or eloquent location, the risk increases with size from 4 to 35%. And in patients with both DVD and eloquent location, the risk increases with size, and it's going up to 38%. And the factors which are influencing the surgical result, generally speaking, are AVM-related factors: size, location, presence of hemorrhage, diffuseness, and patient-related factor. And in this category, the lower the age, the lower the risk also, neurological status, consciousness, comorbidities, but also the surgeon-related factors. That means the experience. So only an example of AVM-related factors, the location, deep-seated around the pineal region. In this particular case, we placed the patient. It was a 78 years old girl with small bleeding from the AVM. We operated side down, and we enter through the interhemispherical structure. We firstly identify the feeders based on the aspect. We placed, in order to check this, I usually place the temporary clip in order to reduce the volume of the AVM and also to reduce the bleeding. And then we start to dissect around. Suddenly, in this position, it's not very comfortable to go far lateral, but you see, we are not using retractors. I am using the aspirator and the bipolar coagulation as a retractor and also as dissector. And we are going along with the AVM, along with the vessels. From time to time, it can produce a rupture of the vessels going into the nidus. Once we identify the nidus, we are coagulating around it, and we are at the end completely, I will go a little bit faster, we are completely excluding from the circulation. And the last step is to coagulate the venous drainage. And you see, in the end, we obtain a very good neurological and anatomical result. In posterior fossa, also the surgery is not very complicated if the AVM is located superficially. This is another child with an hemorrhagic AVMs admitted in emergency. You see the vasculature, it's visible from the surface. As usual, we started to coagulate around the AVM. Firstly, we decompress the clot, we eliminate the clot, and then we dissect the AVM by circumferential dissection and coagulation, a progressive dissection of the feeders, especially the deep-seated ones, and at the end, we remove completely the tumor. There were some deep-seated feeders which we coagulate, and at the end, the deep-seated venous drainage was excluded and removed. So, what about the presence of hemorrhage?
Congratulations, Stefan. We are almost on time.
How many minutes I have?
You already passed 6 minutes.
I already passed 6. So, hemorrhage, according to our study, has a bad influence. It's and I will go to the conclusion because I didn't. So, surgery of intracranial vascular malformation in childhood is not essentially different from that of the adults. We are applying the same principles of surgical planning, the same microsurgical technique, and the same microsurgical gesture. What is different is the long life expectancy resulting in more years of living with an undeteriorated bump in the head. As a consequence, a more aggressive approach is maybe advisable and medically justifiable. Always remember that the child is not a miniature adult, is more than that. Child is better supporting the surgery, more rapid recovery from the surgery, and frequently present spectacular recovery from severe perioperative disability. So the take-home message is a child is not a small adult, but it would become one. Sometimes the decision belongs to you. Do your best and help them to become adults. Thank you for your attention. Apologize, I was not aware about the timing. And I have a great request. If there are some questions related to my presentation, I would ask to ask me to ask the questions now, because I have an emergency in my department. I have to go there. I'm at home now, and I have half an hour to go. So
no worries, Stefan. Thank you so much. Imad, do you want to say something? You are muted. Imad, you are muted. We cannot hear you.
So before Stefan leaves, I have to have one comment from him. The late Pierre Lajoignos, God bless his soul, AVM of the choroidal AVM, vein of Galen in the old days, vein of Galen aneurysm, there's a category called AVM, choroidal AVM, and this is a potential for surgical and interventional radiologists. And the treatment is from the posterior choroidal artery. You can block these, embolize them, and treat them non-surgically. And he has presented several cases by us. He was visiting professor all the time in my institution. There is some noise anyhow. Do you have any experience with these vein of Galen AVMs?
Yes. We have some experience, but not surgically. We are collaborating with an endovascular, very experienced endovascular radiologist, and my impression is that this pathology is mainly for the endovascular treatment.
Yeah, that's why I want to go to the subject, that there is a place for intervention for these cases.
Yes, this is the place for interventional radiology. At the beginning of my experience, there were some cases in which surgeons with experience in pediatric neurosurgery tried to cure them, and I'm not convinced that they cure the AVMs. They cure definitely the patient. So the results is not was not, at least in their hands, too good, and that's why I rather prefer to send it to endovascular treatment. I consider this pathology exclusively for endovascular treatment.
Thank you.
I thank you.
Thanks, Stefan. So as we are a bit delayed, could you please, Stefan, stop sharing your screen?
Yes.
And
apologize. Yes.
Thank you so much, Stefan. That was an excellent overview. And we are 23 minutes delayed, and I see that Professor Qureshi is ready. So Professor Qureshi is the head of the Department of Neurosurgery in Aga Khan University, Nairobi, Kenya. And he's gonna give us some pearls, I'm sure, about how we can squeeze the anatomical knowledge for different pediatric cases, and how it's really key for a safe surgery. Thanks a lot, Moody, for joining us. The floor is yours.
Thank you very much. It's really a privilege and an honor to be part of this amazing galaxy of speakers. I feel humbled to be here. But really, thank you very much, Imad. Thank you very much, Pablo, Vlad, and all the colleagues that have presented today. Ramesh, I see, Samir, I don't see Chandrasekhar, but I know that he's online, and there are so many others who it's a pleasure to be with. I believe you can see my screen.
Yes.
So we'll move on. Just as a follow-up on the excellent talk by Florian, just to reiterate that these are not small adults. And my simple overview of this talk is about understanding the fundamental anatomical differences of the pediatric patient. And I believe, as Florian indicated. It's really a key to safe surgery. The pediatric neurosurgical patient, we need to recognize, and this is aimed towards the residents and young neurosurgeons who are online, that really, as you endeavor to develop a career in pediatric neurosurgery and in your hospitals, you must recognize that these pediatric patients are a very vulnerable group for the reasons even outlined earlier. But in our regions, particularly the low, middle, and income country regions, they represent 50% of our patient population. And the majority, especially in our regions, are dealt with not by specialized pediatric neurosurgeons, but by general neurosurgeons who over the decades of their practice become proficient at dealing with these pediatric neurosurgical pathologies. The nature of these pathologies, both congenital and acquired, and their management are essentially very different or significantly different to those of adults. And therefore, pediatric neurosurgery has developed with the general acceptance that these are best understood and treated in an environment where the whole team is centered towards their unique requirement, not just a single specialist, the neurosurgeon, because that is not the ideal. The ideal is the whole team, and perhaps the whole structure of that unit should be geared towards pediatric neurosurgery. So we'll just go to some of the anatomical highlights that are different in children. The head, brain, and spine are fundamentally very different in children compared to adults, both physiologically and anatomically. The head is disproportionately large and gradually assumes the head-to-body ratio of an adult over several years. At birth, the brain is about 25% of the adult size, even though the body weight is only about 5% of the body size. This changes from infants to adulthood is a continuum. So it's not as if there's a sudden change at a particular point. It's a gradual continuum. About half of the postnatal growth of the brain occurs in the first 2 years, for example. The ratio of the head and neck length to body length is about 25% in infants and is almost double that of the adults. You can imagine if the adult had a head and neck ratio of 25% of the body, we would be walking around looking very, very unreal. So this is a continuum from gestational changes from birth. The disproportionately greater weight of the head also affects the movement of the head. For example, when a child falls or is struck by a moving object, this disproportionality has a bearing on the patient's injuries. A pediatric epidural hematoma, for example, is different. The epidural hematomas in children are somewhat different because the middle meningeal artery, which is in the adult almost protected or incorporated into bone in adults, is not so in the child, and it ruptures easily after trauma to the lateral part of the skull. Where in adults it requires quite a significant fracture that lacerates the middle meningeal artery. In the child, it can rupture very easily from a simple fracture, but also the epidural bleeds also readily occur from the edges of a fracture in children, leading to these hematomas. The thin calvareal bone in children is a particular feature, as we've all noticed, the so-called ping pong fractures that we sometimes see when a child has fallen off a bed and is brought to us with a very significant swelling, yet a dimple when you examine them. The feature, as well as the cranial sutures and the fontanelle, allow for very easy deformation. As I mentioned, the ping pong fracture, with or without fracturing under external pressure. Because of this pliability of the skull, a linear fracture may represent a significant underlying parenchymal injury due to this marked deformation that occurs at the time of the injury, despite little evidence on the CT scan. The growing skull fracture is another particular entity that one sees in children. This is a fracture that is unique in children. It's also called a leptomeningeal cyst in some literature, or growing fractures as they are called, are enlarging skull fractures that occur near post-traumatic encephalomalacia, which you see on the image in B. The exact pathogenesis of this remains unclear, although most are agreed that it is secondary to skull fractures causing a dural tear, which then allows the leptomeninges to herniate through and then causes the parenchyma to then herniate following this, resulting in that fracture gradually expanding and becoming basically a non-union of a fracture. Then the other difference is in ICP monitoring in children. Despite obvious anatomical and physiological differences between children and adults, no age or body size related reference values exist for normal ICP in children. Recent guidelines for treatment of severe TBI recommend ICP monitoring to guide treatment. But what is the normal? Only 10 randomized controlled trials in pediatric patients until very recently have been done on severely injured traumatic brain injuries in children. And these have been conducted, and the level of evidence in observational studies is reported as low or moderate. All centers unanimously reported the use of an ICP threshold of 20, which is what we use in adults. Yet 8 centers further reported 8 specific intracranial pressure thresholds with slightly lower values. One center used 10 millimeter mercury as a value, another 15, another 18. The quality of evidence behind intracranial pressure monitoring and treatment thresholds in severe pediatric TBI is therefore low, and treatment can potentially be improved, obviously, as we go along and begin to gain more knowledge about normal ICP in children. But acceptable levels of ICP and the treatment thresholds vary, obviously, from what it would logically mean with age and the disease, and whether the patient has intact or impaired cerebral autoregulation. And this is continuously changing, as one can imagine, through childhood. It is therefore recommended for us all that normal ICP reference values for infants, children, and adolescents and age-specific treatment thresholds should continue to be further evaluated before we can come to a broad consensus globally. The challenges one faces in ICP monitoring, and some surgeons are very uncomfortable monitoring ICP in very small children. It's because the thin skull may be a challenge for ICP monitoring. Surgeons often reluctant to use these bold systems or even measure ICP in some instances, but it is recommended that one should endeavor to monitor. In the event that one is very uncomfortable or it's inappropriate, then of course there is the option of intracranial pressure transcranial Dopplers that can be used as a way of finding out what the intracranial pressure is. But this is obviously not available in LMIC regions, only in specialist areas, but that's an option. So this is an algorithm for considering whether ICP monitoring should be done. Should it be invasive? If it should always be invasive if it is possible. And if it is possible, then do place the invasive monitoring device. And in the place where it is not possible, it is usually a patient who's awake with normal pupils. The GCS is above 8. If the patient has a coagulopathy, neurosurgical facility is not available, or no operable mass or lesion is seen or is too deep, then perhaps you want to avoid ICP monitoring. But by and large, the rule is in children, one should endeavor to do that. The other area where children, adults often differ significantly is in the area of endoscopic third ventriculostomy. I mention this because it's a very common procedure both in adults and in children. This is the view that we're all familiar with, and this comes from the standard view that we see in adults. And it's a beautiful and fairly straightforward looking floor of the third ventricle, and very enticing to do an endoscopic third ventriculostomy. However, in the pediatric patient, particularly in regions that we've in LMIC regions, we see a significant number of anomalies. So when you go in there, there is no septum, no corpus callosum. The phonoceal columns are large. There are huge interthalamic commissures, enlarged and floating choroid plexuses, a very, very narrow space between the dorsum cellae and the basilar artery. No floor of the third ventricle is sometimes seen, and just a thin arachnoid membrane. What this then means when one is doing an ETV in these children, and I know that Samir was in Uganda when he was working with Ben Wolf, and he can attest that really with these anatomical anomalies, the surgical operating time is increased. And the opportunity to cause damage and increase surgical morbidity also is increased, as was shown by Turi and S. et al. And the success rates of ETV then become impaired. So there is a significant difference from the beautiful image that one is used to in adults to what we see in real in the pediatric patient. So the implication in the pediatric patient is that these variant findings of anatomical structures within the ventricles are frequent. Up to about 25-30% of patients will come up with these variant findings. Normal ventricular findings obviously equate to shorter procedures, times, and success in ETVs. We've had opportunity to do some of these ETVs within about a period of 20 minutes or so, and another one will take us 2 hours because we're just struggling in there trying to find which is the best place to place that, and sometimes one just has to abandon it. The variant ventricular findings increases the difficulty in operating time of the procedure. The next area, which is different from an anatomical standpoint, is the pediatric spine. Spinal injuries in children are a very separate entity, quite different from its adult counterpart due to the wide differences with regards to the scientific studies of measurements and proportions, the so-called anthropometrics, the biomechanics of the pediatric spine, the injury patterns that happen in children, the clinical presentation, the imaging analysis. One needs to have a very acute eye for these this special type of anatomy or radiology of the pediatric spine to be able to say whether or not this patient has had a spinal injury. And of course, that changes the management principles. The predominant mechanism of injury for younger children at 0 to 9 years of age is obviously a fall or pedestrian to automobile accidents. They fall off trees, they fall off by their bicycles. For older children, that's 10 to 18, it's usually the automobile accidents that are the main cause of the spinal trauma in pediatric population. The thoracolumbar spine mainly is injured during the adolescent age because of the activities that the adolescent will be involved with. And the fulcrum of movement in the pediatric spine descends from the upper cervical spine in young children, where C1-2 injuries predominate in the very young, to progressively lower down the cervical spine in the subaxial spine as they grow, when mid to lower cervical injuries become more common. So the very, very young baby or child is more likely to be injured at the C1-2 area, while the slightly older child has a propensity of injury in the subaxial spine. The craniocervical junction is most vulnerable to injury and instability in the young child. Because the articulations are more susceptible to movement than in older children, the ligaments and the paraspinal muscles are weaker, and the dentocentral synchondrosis between the odontoid and C2 body are yet to fuse. So there's your difference. The spine, again, in the pediatric patient. The biomechanical maturation of the spine is a progressive process that only starts to resemble the adult spine from about 8, 9 to 10 years of age. The epiphyses fuse at different times and can easily be mistaken for fractures, as one sees in that arrow. The pattern of injuries is determined by these progressive changes that, as I mentioned, is a continuum from very young to about adolescent and adult. Trauma to the pediatric spine, therefore, can manifest as osseous, discoligamentous, and or neurological injury. So most spine injuries in children occur in the cervical region, as mentioned. In younger patients, these are more often subluxation and dislocations for the reasons mentioned earlier, more often in the upper cervical spine, and more often associated with neurological injury. The shape and density of the bones varies at different ages, hence the need to seek specialist radiology opinion if one is not experienced or is in doubt, rather than call some of these fractures multiple compression fractures. The typical spinal injury in a child, historically, the literature addressing these issues was relatively sparse, but in more recent years, with that increase in the interest in pediatric neurosurgical conditions in pediatric spine, different aspects of pediatric spine have been better appreciated, and now there is an increase in publication in this subject. The incidence overall, however, of spine injuries in children remains at about 2.7 to 9% of the total number of spinal injuries. The typical injuries occurring in children include the occipito atlantal or atlantoaxial dislocation, that's seen in figure 1, atlantoaxial rotation and subluxation seen in figure 2. The child will present with that torticollis. I've borrowed this picture from one of the publications. The torticollis is characteristic. Spinal cord injury without radiological abnormality, the so-called sciura, will also be noted in these children. Note the extensive cord contusion that can exist in the cervical dorsal without any obvious bony or ligamentous injury on the MRI. But the child's flail hand is a pointer that there is something going on. And of course, there is the potential for multiple thoracic compression fractures in children. The other problem, and I think this too was alluded to by Professor Florian, is the challenges posed by the pediatric airway anatomy. The airway anatomy is different from the adult, as is outlined here, and for obvious reasons, and we all understand that. But this particularly poses a challenge during surgery and in the post-operative period when some children need to be ventilated. The difficult airway, the anatomical implications during anesthesia and post-operative ventilation are because of the epiglottis being very large and omega-shaped. Children have a larynx that is higher and more anterior, a cricoid ring that represents the narrowest point of the airway. They have a shorter trachea that bifurcates higher. The mandible is thin and underdeveloped. Their tongues are relatively large for their oral cavity, as are the soft palate and soft tissues of the mouth and epiglottis, which is a relatively longer and stiff structure. The nasal cavities are narrow, predisposing to nasal obstruction. Therefore, these young children are at a particular high risk of airway obstruction. These children, for example, take somewhere between a size 4 tube to a size 5, but the secretions are just as thick as in the adult, and these get clogged up very, very easily. And if it's not noted, as I had the opportunity to witness in one of my patients after medulloblastima surgery, which went very well. Child was awake the next morning, we're thinking of extubating, and we said we'd wean him off gradually. And by evening, he was going into seizures, and people were wondering whether these are cerebellar seizures until such time that the pediatric intensivist was called in to realize that he was running really high CO2 levels and gone into status epilepticus, all because of a tube that was blocked with mucus. The difficult airway during neurosurgery is not only a result of certain unique anatomical considerations, but many of these pediatric patients may also have other congenital conditions that predispose them to the difficult airway. Additionally, the risk is compounded due to surgical considerations for the pediatric patient, for example, the cervical spine positioning, the positioning issues of the child, prolonged procedures that aren't taken very easily by these children. Due to their relatively large heads, for example, when compared to adults, they tend to flex their neck when laid on a flat surface, which may compromise both their airway and their cervical spine. So the take-home message from my brief endeavor to show the differences is that childhood pathologies are best managed in an environment dedicated to their unique requirements, as their nature, both congenital and acquired, and their management are significantly different to those of adults. A thorough knowledge of surgical anatomy and the relevant radiological imaging for particular age of patient must be revisited every time one is going to go in to operate upon a child. And with that, I'd like to thank you very much for the opportunity, Imad and Pablo, to participate in this excellent and very, very educational webinar. Thank you so much.
Thanks a lot, Moody. Thank you so much. So we are 26 minutes delayed, but we will be moving to the next speaker, and I have the privilege to introduce Professor Maldonado from Tours, France, who will introduce our next colleague.
Thank you, Pablo. Good afternoon, everybody. So it's my great pleasure to introduce Professor Francesco Sala from Verona, Italy. He is head of the Department of Neurosurgery at the University of Verona. He's particularly interested in neuro-oncology, pediatric neurosurgery, and intraoperative neurophysiological monitoring, and is our president-elect of the IANS. So please, Professor Sala.
Thank you, Professor Maldonado, and thanks to Pablo and Imad for the kind invitation. Very pleased and honored to be here with you this afternoon. Let me share my screen first of all. Okay, let's see. Okay. Can you see the slides?
Perfect.
Yes, we do.
Okay, very good. So what I would like to do in this 20 minutes is just share with you some I will put a very preliminary work we have been doing in Verona over the last 3-4 years, trying to come up with some novel strategies to investigate brain connectivity during brain tumor surgery under general anesthesia, because this obviously can have important implications in pediatric neurosurgery where AWACS surgery is rarely an option. And I would start from the motor system, because this is certainly the one that we know better from the intraoperative neuromonitoring standpoint. And this is a paradigm which summarizes the standard philosophy about motor evoked potentials in brain tumor surgery. So we know that if we have at the end of the surgery preserved MEPs, that usually predict a good motor outcome. If we completely lose or we have a significant drop in the amplitude of the MEPs, this predicts a long-term motor deficit because of an injury to the cortical spinal tract. But you also know that there are situations where you can still have preserved MEPs, but the patient may have motor deficit early after surgery. For example, if you're operating tumor in the supplementary motor area syndrome. So this is not due to an injury to the cortical spinal tract, but it's due to the fact that this patient developed a sort of akinesia, so they are not able to initiate movement. The SMA syndrome is considered usually benign but there is some evidence of the past few years that it can be less benign than we considered in the past. But there are other examples of situations where you can have motor deficits which are not predicted by motor evoked potential. For example, Lorenzo Bello and his group investigated how to prevent apraxia, which is the inability to perform a skill movement in the absence of motor or sensory deficit. And this can be quite invalid for a patient if he developed this deficit post-operatively. So what they did in the awake settings was to introduce this test where the patient has to rotate this sort of screwdriver. And doing this, they were able to assess and protect the integrity of the circuit connecting the supramarginal and angular gyrus with the ventrolateral premotor cortex. So basically, introducing this test during awake surgery, you can identify and preserve the parietofrontal network. Otherwise, the patient will develop apraxia, but again, this will not be monitored and detected by motor evoked potentials. So the message is that there are motor-related functions which are very important in our daily life, but cannot be reflected by simply monitoring the motor evoked potential that we have been using for many, many years. And of course, the problem is that this last test that I was mentioning requires a collaborative awake patient, which is not the case, obviously, in most of the pediatric neurosurgical procedures. This is a recent study with a review of the literature about awake craniotomy in children, suggesting that in the last 65 years, there have been only about 9 cases reported in the pre-adolescent age group, and almost half of these were reported recently from the Toronto group. But even in the adolescent age group, overall in the literature, there have been probably no more than 50 patients reported. This is another nice study from the group in Lyon, from Carmine Mottolese and Federico Di Rocco. But again, you see here that the median age at surgery was almost 15 years. So they were not children anymore, they were already adolescents. So in the pediatric age group, awake craniotomy is rarely a possibility. And therefore, the idea is to try to find other techniques to test and protect connectivity within the brain. So we have been investigating mainly 2 different strategies. The first is called conditioning of cortical spinal output. So basically, we were looking at how different areas of the brain project and interfere with the function of the primary motor cortex. So we were doing motor evoked potential by stimulating the primary motor cortex, and then we were trying to condition, to modulate this output by stimulating from a different area. And we started to look at the connectivity between the parietal lobule and the primary motor cortex, placing 2 different strip electrodes, so one on the primary motor cortex, as we do usually to perform cortical MEP in brain tumor surgery, and another strip was placed on the parietal lobule. So this is how it works. This is the intraoperative setting. This is the central sulcus, the primary motor cortex electrodes, and those on the parietal lobule. And as you can see here, if you stimulate the primary motor cortex, you expect to have your standard motor evoked potential. This was recorded from the abductor pollicis brevis, a hand muscle. But if you precede this stimulus from a conditioning stimulus from the upper part of the parietal lobule, what happens is that you have a disappearance and inhibition of the motor response. While if you stimulate from the lower part of the parietal lobule, what happens is that you facilitate the response and you will have a bigger MEP. So we have consistently recorded this effect in a group of patients. And interestingly, the facilitatory and inhibitory responses were clustered in the lower and upper part of the parietal lobule. Now, why this is potentially interesting? Because if we are able to reproduce this modulatory effect intraoperatively, the preservation of the effect will likely reflect the fact that the connectivity between the parietal lobule and the primary motor cortex, which is, for example, involved also in the mechanism of praxis, has been respected and preserved. While if we lose intraoperatively this modulatory effect, most likely this will reflect an injury to the pathway. Of course, this will need then a validation with the clinical outcome, the correlation of the clinical outcome, something that we have not reached yet. Most recently, we have been investigating also the connectivity between the premotor areas and the M1. So, for example, we have found that there are inhibitory spots in the superior frontal gyrus. You can have conditioning excitatory effect from the anterior part of the superior frontal gyrus and inhibitory effect to the primary motor cortex from the posterior part of the superior frontal gyrus. Also, you can have inhibitory effect if you stimulate the ventral premotor cortex towards the primary motor cortex. So there is a possibility to investigate the cortico-cortical connection to the ipsilateral M1 from the ventral premotor and the superior frontal gyrus. Again, this may be interesting because the connectivity between the superior frontal gyrus and the primary motor cortex is probably involved in what is called the internally generated goal-directed action. So with our decision to perform a specific motor task. While the connectivity between the ventral premotor and M1 is most likely involved in the visomotor transformation for object grasping. So this is what allows us to perform a certain gesture to reach an object and to be able to grasp that object in the right way. So again, these are possibilities to look at the modulation of the motor function from the primary motor cortex from other areas of the cortex. But again, all these investigation will need then a correlation with the clinical outcome. The second strategy is what is called cortico-cortical evoked potentials, and we have investigated this preliminarily mainly with regards to language function. There are different fasciculi that are involved in the mechanism of language. Certainly one of the most important and most investigated fascicle is the arcuate fasciculus. There are all data from Riki Matsumoto and Hans Luders, which goes back to the early 2000s, where they look at the feasibility of stimulating from the so-called Broca area and recording from Wernicke and vice versa. And they succeed in doing this during awake craniotomies. They describe these two potentials, the N1 potential and the N2 potentials. And they also show that the preservation of this potential correlate with preservation of language function mediated by the arcuate fasciculus, while if you have a drop of more than 50% in this cortico-cortical evoked potential, that usually predicts long-term language deficit. Of course, the monitoring of the arcuate fasciculus does not protect versus all language deficit, but at least this is something that you can try to prevent the so-called conduction aphasia. So what we looked was at the possibility to replicate this study in the asleep setting. So what we did, we looked at the long segment of the arcuate fasciculus using Hardy tractography. Then we use navigated transcranial magnetic stimulation to localize on the cortex the hotspot, which were inducing some language deficit, either hesitation or phonemic paraphasia. And then we put in the neuronavigation system both the result of the navigated TMS and the tractography, trying to localize those hotspots from which most likely the arcuate fasciculus was starting and ending in the frontal operculum. And then we placed two strips, one on the frontal operculum and one of the middle temporal gyrus, and we tried to stimulate from the frontal and recording from temporal and vice versa. So these were the first 9 patients that we studied, and in 5 of them we were able actually to replicate the result from Matsumoto's study. We were able to look at this cortico-cortical evoked potential with some difference as compared to the Matsumoto study, but most likely we were looking at the same phenomenon. Now, this is, of course, preliminary, but it's interesting that other groups have been investigating this cortical evoked potential for the arcuate fasciculus. This is a recent study from Spain, where basically they reached the same conclusions. And so there is more and more interest for this possibility to look at the connectivity between the old Broca and old Wernicke areas, because this may offer an opportunity to at least preserve the function of the arcuate fasciculus, also in those patients where you cannot perform an awake craniotomy, and this, of course, includes children. This is a recent meta-analysis from the Bourdain group, where they analyzed the first 4 papers which address the use of cortical potential for the arcuate fasciculus. And as you can see here, it is quite clear that there is a correlation between the preservation of the amplitude of the N1 component and the risk of developing postoperative language deficit. So again, this is rather preliminary, but there are already some application in the clinical practice. And finally, in the last 7-8 minutes, I would like just to share with you what we have been doing with regards to the connectivity between the cerebellum and the primary motor cortex. This, of course, is very relevant to the cerebellar mutism syndrome. It is my understanding, although I didn't have the possibility to connect earlier this afternoon, that there was a talk by Professor Benesch about this, so you are most likely familiar with the topic. This syndrome is not uncommon in children operated for posterior fossa tumors, particularly medulloblastomas. And these kids present a wide spectrum of symptoms, ranging from motor disorders to changes in speech, behavioral disorders. This is also like the SMA syndrome, supposed to be benign and transient, but we have more and more realized that some of these children do not recover, and some of them can present long-lasting deficit. And this syndrome is most likely due to a disruption of the so-called dentato-thalamocortical pathways. So in a way, it's a supratentorial disorder, which is caused by a disruption of the connectivity between the cerebellum and the cortical and the motor cortex and premotor cortex. So it's a hypofunction of cerebral cortical areas secondary to an injury to the input that comes from the cerebellum. Now, this has been largely investigated both from an anatomical standpoint and also a neuroradiological standpoint, looking at the tractography of the dentato-thalamocortical pathway. But there are basically no intraoperative neurophysiological data on the cerebellum. And so we were very much intrigued by a paper published by some Japanese colleagues a few years ago, where they look at the connectivity between the cerebellum and the primary motor cortex using non-invasive transcranial magnetic stimulation. So what they did, basically, they apply a stimulus to the primary motor cortex, and they modulate this output by applying a secondary stimulus to the cerebellum. And as you can see here, depending on the interval between the stimulus to the cerebellum and the stimulus to the primary motor cortex, they were able to modulate and to have either an inhibition or a facilitation of the primary motor cortex output, depending on the way they were stimulating the cerebellum. So, for example, this was a typical motor evoked potential following stimulation of the primary motor cortex. And then, depending on the conditioning stimulus, they either had inhibition or facilitation of the response. Now, the interesting point of this study was that this effect, this inhibition, was absent in those patients who had specific cerebellar lesions affecting either the cerebellar hemisphere, the dentate nucleus, the superior cerebral peduncle, or the motor thalamus. So in other words, the same anatomical structures which are most likely involved in the cerebellar mutism. So our working hypothesis was the possibility to modulate motor evoked potential elicited by transcranial electrical stimulation of the primary motor cortex using an appropriate intraoperative cerebellar cortical stimulus. So we were looking at the possibility to replicate in the operating room what the Japanese colleagues have done in the neurophysiology laboratory. Why this is potentially interesting? Because if we are able to obtain this potential, an inhibition or facilitation of the muscle motor response would probably suggest that the dentato-thalamocortical pathway is being activated. And therefore, if we are then able to preserve this modulatory effect, most likely this will predict the preservation of the pathway, while if we lose this potential intraoperatively, that may reflect an injury to the pathway and possibly predict cerebellar mutism. So the first step that we have addressed so far was to try to replicate the Japanese study in the intraoperative setting. That's what we did. So we studied by now probably about 20 patients. These were the first 16 patients. They were both adults and children. So here we were not looking at the clinical outcome. We were just looking at the feasibility of the monitoring technique intraoperatively. So we were using a transcranial electrical stimulation to record from the hand muscle for the routine monitoring that we use during posterior fossa surgery. And then when the cerebellum was exposed, we applied a cortical stimulus to the cerebellar cortex using the strip electrode. And with this stimulus, we're trying to modulate the outcome from the primary motor cortex. And what we observed was, as you can see here, an inhibition of the response when stimulating the cerebellum before stimulating the primary motor cortex. So this was a child with a benuloblastoma where we applied this technique. We placed the strip electrode. This was the test stimulus by stimulating the primary motor cortex. And when we applied a stimulus to the cerebellum before testing the primary motor cortex, this is what happened with the conditioning stimulus. The motor cortex response was much smaller. In this particular case, the child didn't develop cerebellar mutism, but of course, this is just an anecdotal case and doesn't mean anything. But we look at about 10 patients, and when we cluster all the inhibitory or facilitatory response using a model where we report all the individual hotspots of the different patients, it was interesting that both the inhibitory and facilitatory responses were not just dispersed and scattered around all the cerebral cortex, which would have most likely suggested a non-specific result, but vice versa, these were clustered in specific area of the cerebellum. And the interesting point is that the location of the conditioning effects was very much similar to the expected somatotopy from animal models, and also similar to what to expect from task-based fMRI study on the cortical cerebellar representation of the limb, muscle, and face. So again, this is very preliminary, because then the next step will be to correlate these findings with the clinical outcome of this patient. But what I've tried to share with you in this afternoon was the possibility that we have nowadays to look also in the sleep setting at some connectivity, particularly with the primary motor cortex, which have a clinical relevance and that cannot simply be reflected by monitoring of the motor evoked potentials. So there is still a long way to go to get these into the clinical practice, but I'm very happy to have the privilege to work with this young group of neurosurgeons, neurologists, and neurophysiologists, and I'm very much in depth to all of them for their enthusiastic work here in Verona over the past few years. So I would stop here, and I'm happy to take any question. Thank you.
Thank you, Professor Sala, for your excellent lecture. So interesting. We really see you're pushing boundaries in this area. I see in the program there is a discussion session which is foreseen. So I will ask the moderators to take over if you agree, Pablo, Professor Chandrasekhar, and Professor Thomas Santarius. I don't see Thomas here.
Is Dr. Santarius there already?
I think Tom cannot join, so if you don't mind to take over.
Of course.
So I think as we have not been, as we did not have a chance to talk on individual papers, I would probably start, though Samir has gone. There are no questions, but I think experience-wise, we have also found that this corridor is extremely useful for endoscope-controlled or endoscope-assisted surgery. And one of the main benefits we find is that you do not have to disturb the veins, which is important in terms of finding a good corridor, as well as in terms of, not stretching too much by retraction. So that forms a great advantage, and you can really go lateral supracerebellar, as he emphasized.
May I ask you one question, Dr. Chandra, since you are pediatric and you have a vast experience, and for the podium as well, the unilateral endoscopic assisted, do you use only dynamic endoscopy, or you use a scope holder to hold the scope and use your hands?
I hardly ever use a scope holder. It is all dynamic endoscopy, because the main, disadvantage of using an endoscope is loss of your 3D perception. And if you use the freehand endoscopy, you compensate for that very well. Recently, we have acquired a Kynavo, where it becomes a little easier because everything is attached to it. But we are still not very comfortable. We are comfortable using our system because the image quality of Kynavo is not up to the mark in terms of their endoscopy, current endoscopy equipment. The second paper, I think, which was touched upon again by the talk Francesco just gave. So the question, Francesco, is that as it came out in Venice's paper, he's not here. We see that you can still get cerebellar mutism even if we go by telovelar approach occasionally. So how do we, if we say that most of it belongs to the superior cerebellar peduncle and the pathway above, how can you explain? How can we explain that? And can we really monitor for it in our current armamentarium? Francesco, are you with us?
Sorry. Yes. Can you hear me now?
Yes.
Yeah.
Yeah. Okay. Hi, Chandrasekhar. Nice seeing you. Thanks for your question. Yeah. So, the issue of the approach has been debated for many years. I remember Ezio Di Rocco almost 20 years ago said that there is no really difference on the approach. And also this now a large multi-center Nordic study in Europe, which has not shown a difference in the incidence of the syndrome. Either you go, if you split the vermis, or you go telovelar. I think one of the problem, even if you go telovelar, is if you place too much retraction, particularly bilaterally. I never use, for example, the spatula bilaterally. If I need to use it temporarily, I use it only on one side to avoid a bilateral injury, if any. So, it is still possible that you can injure the dentate nucleus with either one of the approaches. We don't have any technique nowadays to prevent that. We are just looking at the possibility to, so basically we have shown, but this was a small study, that it is possible to replicate that kind of monitoring from the cerebellum to the primary motor cortex. What we need next is to have other groups replicating the same data, to have reproducibility of the methodology. And then, of course, we have to start to look at the outcome and see if those patients who develop the syndrome are those where we lose this effect intraoperatively, and vice versa, if whenever we are able to preserve this neurophysiological effect, those patients will not have the syndrome. But the problem is that, as we know, I mean, this is a relatively, let's say, not uncommon syndrome, but there are not that many patients with posterior fossa tumor. So if we look at all the incidence of cerebellar mutism, we will need a very large multi-center study before we come out with some robust data on the value of the neuromonitoring. So I think we are still far from there. But what was fascinating to me is that when I look at the literature, as a neurosurgeon and also from the neuromonitoring perspective, we pay a lot of respect to the brainstem. So we are very much worried about injuring the brainstem, and we do all kinds of neurophysiology to protect the brainstem, but we never cared of the poor cerebellum. We always scotomize the cerebellum as an, something which is relevant from the motor standpoint, but not much more than that. And now there is strong evidence that the cerebellum has also implication in cognitive disorders and has also cognitive role. So we should probably pay more attention to the cerebellum in the future.
But do we currently have a capacity to monitor cerebellar function during surgery?
Not now, no. I mean, before our study, there was only one paper on intraoperative neurophysiology of the cerebellum from Lyon, from Carmine Mottolese group. They looked with their neuroscientists, they were looking at the somatotopy of the cerebellar cortex. But that was not very useful from the monitoring standpoint. So at these days, we don't have yet a robust neuromonitoring technique for the cerebellum. But I think we will need one. That's why we are trying to learn more about this.
Pablo, you had something.
Yeah, I wanted to ask you, Francesco, if there is any role of, you talked about briefly about transcranial magnetic stimulation on the motor pathway as you prepare your navigation things. Is there any role for that in your research? Is there any spot to check how stimulation on the cerebellum could influence somehow the M1 response?
Yeah, no, this is definitely a good point. Well, this is what I would like to start, because we didn't start with navigated TMS in children yet, but there are some, for example, in Barcelona, Pepe, with some of the neurophysiology, they are doing some nice study of TMS in children. So you need to do it in children, of course. And definitely, I think there is a role for that, because the Japanese study showed that you can modulate the cerebellum, the motor cortex, by stimulating the cerebellum. So, also to have some pre-surgical study may have some role, but we don't have experience with that clinically yet.
So, while we are on Francesco, can I ask you, just make a small comment and ask one more question? One is, we've not published, but we have actually done awake craniotomy in children between 9 to 12, about 4 of them. But I think they require intensive coaching, and it's not very easy. So it's very nice to hear from you that we have some reliable, mainly for language function. I think, do you think the current methodology which you have developed, that should help us in preserving the language function in children? How robust is the evidence?
Yeah, it's more or less the same issue as for the cerebellum. I think what we have is still very preliminary, but actually for the monitoring of the arcuate fasciculus, there are now a few groups who have published very similar work and data. And so I think this will probably increase substantially in the next few years. And the answer is yes. I mean, if we are able to have a reproducible methodology to monitor the connectivity between the temporal and the frontal gyrus, this might eventually help to decrease at least the risk to injury the arcuate fasciculus. Of course, language is much more than the arcuate fasciculus. And the other problem is that we don't know exactly when you can stimulate from the frontal and record from the temporal, but there are many as Pablo knows very well, there are many white matter tracts that connect the two. Not all of them represent the arcuate fasciculus. So we still have to refine the methodology, okay, to make sure that what we are really looking at. But there are already some data showing that it is possible to monitor the arcuate fasciculus, and some data from Matsumoto, he's the first group in Japan who introduced this technique many years ago. They show clearly that if you preserve that cortical potential, that will be predictable of the language outcome related to the arcuate fasciculus function. So I think this will become probably a useful technique also for pediatric neurosurgery. I hope.
Do you have a comment on use of the new or not so new developed concept of connectomes and various areas? Do you think that has influenced the monitoring to any extent?
I didn't hear about what?
Connectomes.
Yes.
We now try to segregate areas more than what we have generally been talking about, and talk about the connections as one of the most important thing. Has that influenced your practice of?
Yeah, I think that in general, no. If you look back for the last 10, 15 years, we have seen a lot of interest awake, almost 20 years now, for the awake craniotomy that we abandoned for many years. So, of course, the possibility to investigate all cognitive function in awake patient, this is one. The other one is certainly the advent of the concept of the connectome, which in terms of intraoperative neurophysiology has been reflected by a progressive shift of the interest from cortical mapping to subcortical mapping. So we are now much more intrigued by subcortical mapping, trying to find the subcortical function boundaries when you're removing a glioma in order to understand when to stop with the resection. So in a way, I would say subcortical mapping has probably become even more interesting and relevant than cortical mapping. And certainly the idea of the connectome, and of course with all the tractography, this has quite changed the perspective over the last now many years in glioma surgery.
So that brings us to Roy for the various fibrous tracts, which you beautifully demonstrated. Is Roy with us?
Yes. Yeah, he is there.
So, Roy, I mean, you have actually shown so many techniques that I really wanted to find out from you about, disconnecting the posterior commissure. Anterior commissure is being more and more talked about, but are you doing that regularly, or are you doing that in specific subjects?
Well, we have done it now for 30 patients. Patients with multifocal, intractable, multifocal, bihemispheric epilepsy. So these are patients who are actually developmentally challenged, not some severe and some moderate, but these are children with intractable epilepsy, and the idea is to control the severe forms of epilepsy. You won't be able to control the small focal seizures, but at least for drop attacks. So if you look at the literature 30 years back, what was a candidate for corpus callosotomy slowly became a candidate for VNS. So we're talking about the same group, Lennox-Gastaut, or all these kind of syndromes which have bihemispheric intractable epilepsy. So if you have that group of children who have hundreds of seizures per day, the alternative is two at the moment. Both good alternatives. One is VNS, and the other one is a complete callosotomy. Now, you can increase the efficiency of your surgery if you combine the complete callosotomy with an anterior commissurotomy and a posterior commissurotomy. But to do this, it has to be endoscopic, and it has to be flexible endoscopy. So we have now a series of, I think now it's about 30 patients, all operated in Tumen along with Professor Sufyanov. We have not been able to introduce the flexible endoscope as yet in Switzerland. I tried. There are too many regulatory restrictions of the flexible endoscope in Europe that they just will not let us do it. They pushed us to use a disposable flexible endoscope, which was, I think, marketed by the Boston group. But I tried with the flexible, the disposable one, and the optics are so poor, I do not feel confident enough to do it. So at the moment, my experience is with rigid and flexible endoscopy as what we are doing in Tumen. Now, after the whole war problem, I have not gone back to Tumen for 3 years, so I don't know how many more cases have been done there. So that's the limit of my experience.
In terms of procedural difficulty, just one more thing. Most of the cases which you are doing probably have atrophic hemispheres and the ventricles are fair size. Have you tried to do this in cases like hemimegalencephaly or in cases where the ventricles are not enlarged at all?
No, because hemimegalencephaly by definition is a unilateral disease. So there you have the treatment for that is hemispherotomy. So this procedure does not have any relevance in any hemispheric disease. It has to be bilateral, and as you rightly said, these children always have larger than normal ventricles.
So you would do a parasagittal procedure, regular one in those cases?
In these patients with bihemispheric disease, I would do a disruption of the anterior and posterior commissure and habelular commissure if possible by an endoscopic flexible endoscopy through the third ventricle. And then inside the ipsilateral lateral ventricle, I would do a parasagittal complete calosotomy.
Anyone else would like to ask Roy any questions before we move to the next one? Imad, Pablo, you have any comments?
No, they're well covered actually. I learned a lot. And I used to do the epilepsy, but things change, and very interesting topics. And thanks to Francesco as well. He added a new line of research and implication for clinical use as well.
I'd like to ask about the technique for the posterior commissurotomy, Roy. I never asked you, is the way in which you showed us the regular way? I mean, you are using the forceps, getting it and just pushing away. It's not any else.
Yeah, with the endoscope, I agree, Pablo. It looks very brutal, but
no. It's not that.
But yes, the easiest is to do it with
being divided with a spade kind of an instrument.
Yes, it's actually very small, and everything looks very big with an endoscope. It's actually not that big as you imagine, and then you pull it so as to rupture it. And if there are these small bleeding vessels, they're usually of venous origin, and you can easily coagulate it. But what's most important in this procedure is to have a little bit of a high pressure irrigation system. And the best high pressure irrigation system I borrowed from the orthopedicians for arthroscopy of the knee. So we have the orthopedicians giving us high pressure irrigation and the urologist who move the endoscope around. So it's truly a multi-speciality endeavor.
A lot of people busy, yeah?
Yeah.
I have one question to you, Roy. I'm trying to facilitate for you the rigid scope. When you go from my experience in pineal region tumors, and when we put the rigid scope there to take a pineal region tumor, we enter to the posterior third ventricle. That posterior commissure is in front of you, and you don't need in that one the flexible scope per se. And usually I will cut it if I need. I cut it with the knife or whatever. I want the suction. I can disconnect it very easily. Of course, it's entailed you might not reach the anterior commissure, but even if you have a large ventricle, you will reach on a posterior approach. You are talking about the need of flexible for more an anterior approach, isn't it?
Well, yes and no, Imad. You're talking about an extra cerebellar approach in which you go from outside into the ventricle. Now, here you have to imagine that we also need to do a corpus callosotomy. So you will have multiple approaches if you do that. So the easiest way is to have a lateral trajectory to get into the lateral ventricle, and that gives you access to foramina Monroe, and that with the flexible you can do the 2 commissurotomies. Then you come out, and with the rigid you can do the entire corpus callosum. So that doing it open may be a bit of a stretch. Maybe it's possible, but I've never thought about it. This can be done through a small burr on the lateral surface, and with that you can do the entire procedure.
Right. The 3-in-1.
Yeah.
Victor, do you have any comments for the various tracts which Daniel talked about? Any thoughts? Oh, he's left, I think. About Stefan's presentation, he is not here. I think he's in heart. Dr. Victor, do you have any comments on the fiber tracts disruption?
No, Professor Chandrasekhar, it's really amazing. The lectures, the videos, pictures, and I think now we are excited about the success of the study of neuroanatomy, especially white fibers. Thank you. That's it.
I think various peculiarities which Stefan mentioned about pediatric AVMs. I think one other thing which has come fairly well in literature and had a couple of cases is the recurrence after angiographic obliteration. And it seems to be almost 3 or 4 times higher percentage than adult population. So you need to follow these children more common, and this is one reason why people are saying that embolization may not be such a great treatment, because the angiogenesis keeps on going, and you it's either surgery plus minus radiosurgery. That's one concept which seems to be coming if you look at the literature on recurrent AVMs. Anybody would like to comment on that?
Well, one comment for Stefan. He showed one case of, I think, an occipital transtentorial approach to reach a meso part of the occipital and the pineal region. And my recommendation for this approach, you need some kind of drainage. Although he was not using the retractor as he said, but the occipital lobe stood in front of him and he kept punching with the suction softly. But I think drainage, and has been the recommendation, if you want to use this one and make use of the gravity of the occipital lobe ipsilaterally, then Absolutely. You need to put the drainage, either lumbar or ventricular drainage, to relax this occipital lobe. I just want to give this recommendation. Thank you.
And then I think Moody showed us some very good examples as to how children are different and their problems are different from adults. And I didn't quite understand, Moody. You were making some point about the third ventricular anatomy and its influence on endoscopic third ventricular ostomy in adults versus children. Can you just explain to me
What I meant was, when those of us who do adult happen to need to do an adult ETV, the typical anatomical textbook picture is what we meet. We hardly ever meet the kind of pathologies that we see in the pediatric age group, particularly where it's such a huge problem. Neonatal hydrocephalus is such a huge problem. And when we do that in the pediatric age group, we do see the normal anatomy as well, but there's a significant number of children where we find this variant anatomy. So those who are practicing or interested in practicing pediatric neurosurgery need to recognize that variant anatomy is something that they will encounter, and they need to be familiar with that and how to obviously get around it, because the first time you see it, you really don't know what to do with that patient, and you just abandon the patient and you do perhaps go for a shunt. But knowing that there is a significant difference in certain subgroup of pediatric patients is what I was trying to highlight.
Two of the things which we have commonly seen, if you try to do ATV in a spina bifida child, you find frequently that the foramen of Monro is not much enlarged, in spite of reasonably large ventricles. And the massa intermediate are usually quite big. So you really need to use a very, very small endoscope, or you need to use endoscope without sheath, etc. And occasionally that may stop you from doing the procedure. And secondly, we see, though there has been no, I mean, it's like there is no clinical evidence of any infection, but many a times we see that looking at the ventricular walls, choroid plexus, you realize that these children have probably had some neonatal infection even in their ventricles. That seems to be very, very common. I mean, I think we see it in almost 20 to 30% children. Is that true in your part of the world as well?
Exceedingly so, so much so that we endeavored to provide a grading system that would lead to a ETV success, and we called it the African Federation of Neurosurgical Society grading, the AFNS grading, where grade 1 would be completely pristine ventricles with a very normal looking anatomy that I showed in the adult, right? And grade 2 would be where you then have these what look like particular hemorrhages all around, and these are possibly evidence of past infection. Grade 3 would then be A and B. A would be where there is almost obscure anatomy, yet there are these anatomical variants along with it. And grade 4 is what we described as the cheetah appearance, where there's been such florid infection that when you put the endoscope, it looks like it's a leopard skin or a cheetah skin appearance. And we've seen that. And you look at the cheetah skin photograph and you look at the ones that you see under the endoscope, they look identical. So we endeavored to create an African Federation of Neurosurgical Society grading system pointing towards that. So yes, we see that very many times in these outreach mission sites where we see these children who've had these infections, and that grading system was what we endeavored to promote, but it hasn't yet gone into big time acceptance. What I did want to ask Francisco, if I may, take the opportunity, Chandra, if I may, I know we're running out of time.
Please.
There, you've obviously pushing the envelope as far as subcortical neuromonitoring, which will obviously help in children as well. In terms of language, what we found, or at least read, and I've experienced that with my own patient as well, a patient who has become temporarily aphasic following surgery, which during awake craniotomy, he was actually talking, and then towards the end, just a small thing, and he stopped talking. For several days after, what he was able to do is when I asked him to sing one of his favorite songs, he was able to sing it, but not articulate anything else. So I'm wondering, and the explanation thus far has been that music and singing comes from the right parietal region, and perhaps that's why that is intact. But is there a possibility of using that the possibility of utilizing the patient's ability to sing a song during neurophysiological monitoring to determine whether you are interfering with some of the speech areas? I'm just thinking aloud, but it's always fascinated me that the patient was able to sing a song but not able to speak when you asked him to say something.
Yeah. Well, Mom, I have very limited experience with awake surgery because for various reasons in Verona, we have always been a little bit biased towards sleep surgery using a lot of neuromonitor for motor evoked potential. So I have not much experience with awake surgery and assessment of language. What I can say and share with you is that we do also have similar experience with patients that they do well during the surgery and then they start to be a little bit worse towards the end of the surgery. And they get much worse in the first few days right after surgery, probably because of some edema or some of disruption along the tracts, and then they get better. certainly, the singing and reading and speaking, they go through different fascicles. So I had a very good friend of mine who recently needed an operation for a parietal left lesion, cortical subcortical, and I didn't have the appropriate neuropsychological support here there in terms of expertise of the neuropsychologist team to do the surgery. So I sent him to Lorenzo Bello in Milan, and I went to see the operation. And the peculiarity why I sent the patient to him is that this patient is a professional musician. And so, I was worried about if you don't really look with a lot of experience and carefully in testing music-related skills intraoperatively, you might have the patient able to speak, but not maybe able to read music anymore or to play an instrument. And it was quite interesting. They did a around-the-clock testing, having the patient reading notes, but also listening to notes and being able to discriminate a sol from a C or do or re or the other notes. And so the main point is that you need a lot of neuropsychological testing intraoperatively to test the different cognitive skills. And of course, those of a musician are different from those of a professor of language or mathematicians. So we need all those evaluation to address the proper subcortical function. But we don't have much personal experience with the awake assessment.
May I have one comment on this? Actually, Moody, you mentioned it. You are right. It's a different location. And in the famous handbook of neurology, in one of the chapter called amasia, inability to appreciate music or conduct music, and this is right hemispheric, is not on the left hemisphere. So it's a different location and regional anatomy. I think this is one of the explanation perhaps in these cases.
Thank you. Thank you. Very interesting.
I think we have
Pediatric Neurosurgery Forum, but I've learned so much today.
We have completely run out of time. I think thanks, Imad, Pablo, and Professor Nair hasn't made any comments, so maybe we can have some concluding remarks and back to Pablo anyway.
He Ramesh had to leave. He just left to do a boring meeting with the administrators of his hospital.
Oh, it's more painful. It's a very painful exercise.
So Imad, thank you so much again for putting the ingredients.
Thanks, Pablo, for preparing this, and thanks for all the speakers and the audience as well. We are waiting for their comments to try to yield on their demand and needs. And I hope all of you have a nice evening. Yeah, Chandra, I want to say something. Chandra?
No, there is nothing in the question box. I just checked.
Oh, I checked it.
There were any questions?
Everything is answered.
Yeah.
Very nicely.
Pablo, please conclude it, the session.
No, I just want to ask you for permission to take a group picture. So if you allow me, I will take a snap.
Yeah. Great.
So thank you again.
Smile.
Smile.
Right.
Done. Thank you again for taking your time out of your families and patients, and I really hope to see you back again. Francesco, thank you so much.
Thanks, everybody.
Thank you all. See you soon.
Thank you.
Bye-bye.
Thank you.
Bye. Thank you.
Bye-bye, Roy. Thank you.
Thank you, bro.
See you. Chandra, thank you very much.
Bro, thank you. Have a good day.
Takashi.
Yeah. It's now 2 a.m. So yeah, I really enjoyed.
Thank you for being there till the end.
Yeah.
Thank you.
Thank you. Thank you. So very informative lecture. Thank you.
Thank you, Takashi. Stay in touch.
Kasadi.
You were offline. We couldn't see you till now. Even now. Víctor, gracias por unirte a la banda. Nos vemos pronto. Abrazo grande.